Welcome to this first AHP session of the Symposium, and also to my fellow chairs, Sarah Ajaz, Simon Kopak, Mary O'Kane, Tamara Paplampu and Manisha Sharma. Our first speaker is Dr. Yitzka Graham, who almost needs no introduction. Dr. Graham is well known in the bariatric field and is head of the Helen McArdle Nursing and Care Research Institute and Associate Professor of Health Services Research at the University of Sunderland. Further positions are held within BOMS and internationally. Without further ado, I'd like to invite Dr. Graham to begin presenting Putting on a Brave Face, AHP Wellbeing and COVID-19. Over to you.
Hello, good morning. My talk is pre-recorded. Opening is Health and Wellbeing of Bariatric Multidisciplinary Teams. I think the last 18 months have really highlighted. Good morning. I'm Dr. Yitzka Graham from the University of Sunderland. Thank you very much for the honour of presenting at this year's LIBSS 2021 virtual conference. What I'd like to speak to you about this morning is health and well-being of bariatric multidisciplinary teams. I think the last 18 months have really highlighted the importance of mental health and well-being amongst our teams. So I'd just like to sort of really make that an open subject in terms of my lecture today and just really encourage a bit of debate and discussion around the subject, which is often quite hidden. So the aims today is really just to situate the presentation in the operating room, because I think that's very much where it starts. We're talking about a procedure that the multidisciplinary team is wrapped around, but I think there are some things in terms of the rituals in the operating room which we can tease out and bring into the outside the operating room into multidisciplinary bariatric care. Talk about the interpersonal dynamics of MDTs, the impact of COVID-19 on MDTs, exploring health and well-being, and obviously at the end, making recommendations for practice and support. So to understand surgical teams, and again, take the context out of the operating room into bariatric MDTs, I think it's really important to understand the environment in which they live and thrive. So if we look at the rituals in the operating room, rituals are ceremonies consisting of a series of actions according to a prescribed order. And the rituals contribute to the efficiency of a technical, goal-oriented scientific activity such as surgery. But as I say, this is just to set the scene, and we will be pulling these out and looking at it outside the operating theatre. So rituals permit autonomy of action to participants. Each member of the surgical team has a specific role. This enables functioning in circumstances of ambiguity with many unknowns. And again, I think we can all relate to that in terms of patient care. And observed rituals help to establish operating rooms as a space. So it sets standards for appropriate behaviors, indicating behavior categories and the limits of these. The meaning of words are exclusive of setting, and it expresses beliefs and values. So if we look at the interpersonal dynamics of surgery in the context of an MDT approach to bariatric surgery, the quality of surgical team collaboration, and again, multidisciplinary bariatric surgical teams, is rooted in team members' knowledge and skills in relation to procedures, knowledge of their own and other team members' roles, and communication processes that support appropriate modalities of collaborations, notably in the face of unexpected surgical challenges. And I would say, if we look at surgical challenges and look at that in terms of, unexpected patient care issues in the wider context of, pre, peri, and post-operative support. So if we look at these dynamics, 4 facets here. So we're highly dependent on each other. So there is that mutual respect for positions, no matter what part you play in that bariatric MDT. We're all used to working under time pressures. And again, I think time is something we've all become aware of. I think our working days have been extended. The time we spend at work is sometimes blurred into our home lives with some home working practices. Communication and effective team working is crucial to patient safety and clinical treatments. And sometimes our processes of communications have been severely disrupted during the pandemic. And also there's relational coordination, which I'll discuss with you in the next slide. So relational coordination mutually reinforces processes of communication and relating across areas of expertise for the purpose of task integration, which is obviously patient care. There's shared goals, knowledge, and mutual respect for each member of the team. This is supported by frequent, timely, and accurate communication, which focuses on problem solving rather than apportioning blame. So if there is a difficult patient, a difficult sort of case study, difficult in the provision of care, it's relational coordination looks at focusing on how do we solve that problem, not who do we blame for the fact that this happened. That's not what's expected here. But I think in terms of looking at that, in terms of us as a bariatric MDT, it's really important to think about this concept. So relational coordination has been found to predict higher levels of quality, efficiency, job satisfaction, engagement at work, psychological safety, and the ability to learn from errors. I'd like to move on to the impact of COVID-19 on bariatric MDTs and just thinking about what we've highlighted before. The implications of the pandemic for bariatric MDTs are disrupted processes and communications. Again, things have fundamentally changed and been challenged over the last 18 months. In terms of altered patient care disrupting that communication, I think the one thing that is really coming across loud and clear in the research I'm doing is that rapid move to remote consultation. So we've had video and telephone. A lot of us have been working from home. There's been no transition or time to adopt and implement this. This virtually happened overnight, and we haven't had the luxury of having that adjustment. So I think that has impacted on communications and on team dynamics, which we've almost had to renegotiate and reestablish. Many of us were redeployed to other clinical areas to meet the demands of the pandemic on patient care. Many staff were furloughed, they were taken into other areas, or they were at home, that feeling of frustration of not being able to work or be in that environment that is the safe and very comfortable known environment. There have been recruitment freezes, so in terms of staff to support delivery of care, that's been adversely affected. There's been impact on surgical training and education also into the broader non-surgical aspects of the bariatric MDT. You know, many people haven't had, students or trainees haven't had the opportunity of those face-to-face contact and that experiential learning, and that has impacted on development and obviously the workforce flowing through. And then there's a move away from the specialist surgical environment and the rituals associated with surgical and MDT practices. Our world has been altered. So the impact on the health and well-being of the MDTs, the social distancing has led to complexities in communication in the operating room and also into the wider MDT. Established teams may be separated, thus routines and processes disrupted, getting to know new and different colleagues, perhaps in a different context. New behavioral expectations need to be embedded into practice. So again, it would be maybe the social norms around the video and the telephone working. So in many ways, face-to-face contact is so much easier because you've got the whole person in front of you. You can read the body language, and there's a barrier almost with the video or the telephone communications, but it's to try and understand that and how we implement, understand it, and again, sustain it. These are all accountable for infection control measures, which is something we still 18 months later have to be cognizant of. But what this resulted in is increased levels of stress and pressure on the bariatric MDTs. And there's three concepts that I want to discuss each in turn. That is of emotional labor, moral injury, and compassion fatigue, and looking at the sort of lower resistance that is quite potentially existing 18 months into our altered world as a result of the pandemic. If we look at emotional labor, this is something that's defined as managing or suppressing emotions in order to portray oneself on a socially constructed view of a profession to produce a desired expectation in others. So just two examples here. If we look at the social construct of a surgeon needs to present qualities of trust and confidence and being in control to the patient. You know, the patient is going to lay himself open to be operated on. You know, he or she is going to be asleep, and they need to know they can trust and you know that that patient is competent and is got things under control, if you like. If you look at the social contracts of nursing, nurses, it's a very caring, very compassionate profession, and nurses need to display this. And especially think of some of the complexities of some of our patients. They rely very much on that support of the nurse. Now, it may be difficult, owing to stressors associated with the pandemic, of actually sort of carrying out these roles and that expression, putting on a brave face and keeping up those appearances. And again, we have patients who are quite challenging and complex, and emotional labor may be quite draining. And I think this has really been exacerbated in the last 18 months. So really just to be aware of the stress of keeping up that brave face all the time. If you look at moral injury, this happens when we perpetrate, bear witness, or fail to prevent an act that transgresses our deeply held morals. So I think none of us could have prevented the pandemic. Again, it's put an additional layer of burden of care and complexity into patient care. And I think very much with moral injury, we know what patients need, but in the current situation, we're unable often at times to provide our usual levels of care face-to-face or whatever, owing to external factors, and these are beyond our control. And there is that thing, if we could control it, we could do something about it. So it's sort of understanding on a very subconscious level that this can't, we can't do anything about it. We need to learn to live and negotiate into this world. And if we cast our minds back to 18 months ago, the global postponement of bariatric surgery in March 2020, we knew that we had patients on the theatre list, patients who were physically and psychologically prepared for surgery, but often unable to comply with the recommendations owing to the effects of the pandemic and the worry that this brought. So we had pre-surgical patients putting weight on, couldn't follow, couldn't go out and exercise, couldn't adhere to those post-surgical recommendations, but there was nothing they could do about it, and it was nothing we could do about it. So how we sort of supported them. And it is that duality of wanting to provide care, but unable to do so. And that can lead to moral injury. So again, a concept really just to think about and reflect. And finally, if we look at compassion fatigue, and this is the convergence of secondary traumatic stress and cumulative burnout, a state of physical and mental exhaustion caused by depleted ability to cope with one's everyday environment. Again, if we look at this in the context of the pandemic and the pressures needed, and we are in professions where we care, we look after people, this compassion fatigue can inadvertently affect patient care, our relationships with colleagues whom we rely upon for support. Compassion fatigue is a trigger for development of poor mental health, and it really is important to identify and address it and put factors in to increase resilience to prevent burnout, which unfortunately is a consequence of compassion fatigue. So just again, looking over the last 18 months, we are still negotiating a complex, ambiguous situation. We have lowered resilience in an ongoing crisis. We've got the winter pressures that are coming in. We don't know the impact of the flu this year, because last year, obviously, we had 2 lockdowns. And again, there is the booster vaccination uptake and the impact that will have on coronavirus cases and our ability to provide patient care and reduce risk of infection. So the long-term consequences are considerations. So we've got workforce shortages, students and trainees in all MDT roles. We have had sites of, not pursuing the careers that they originally intended. We have retirement or career changes of individual healthcare professionals in bariatric MDTs. I do know colleagues reporting, planning on retirement early or perhaps moving into a slightly different role. And again, it is that long-term and well-being of bariatric MDTs, not only personally, but as a collective of that team working. And again, how do we sustain these new norms of bariatric care and practice, which have been sort of thrust upon us? And again, that period of adjustment, which we never really got to experience. So in terms of recommendations, and I say I don't have a crystal ball, and I think this is one of the situations, if I could wave that magic wand and make everything better, I could, and I'm sort of frustrated that I can't. It's probably a bit of moral injury in there, but I think in terms of recommendations, so all members of surgical teams need to be aware of the potential impact of the ongoing pandemic on mental health and well-being. Consider the impact of changed and new ways of working on your well-being. And again, I really highlight the point of video conferencing and telephone as a face-to-face appointments, but I mean, it is something we have to live with. But again, maybe looking at what is working well, perhaps what could be developed further, not only to make things easier for yourself and the patients, but also what about colleagues, looking at, can we just unpick this? Can we adjust anything? How do we make it better? And again, reflecting on the concepts of emotional labor, moral injury, and compassion fatigue in terms of yourself and your colleagues. So I guess it's sort of three distinctive ways of looking at what's happened over the last 18 months, the impact on yourself, and integrate active mechanisms of coping and resilience. What support is available to you? Do you feel you need support? And again, I think it's really important to be honest with yourself. There's formal routes such as counseling available in the workplace, your own healthcare professionals that you deal with. And the one thing, again, that's been reported consistently time again to me is the role of informal support amongst colleagues. And I think what's come out and just seems to be quite frequent are these sort of WhatsApp group chats with colleagues. It's a way of staying connected. It's a way of people feeling less isolated. And I said, because it's informal, it can, you can sort of provide, just happy informal things like hope you're feeling well, that emoji smiley face or something, which is quite appropriate in a WhatsApp chat. That's the way you sort of send a WhatsApp chat could sort of make the difference between a bad day and a much better day for people. But that informal support, I think, is really, really important. And again, to prioritize self-care and incorporate this into your daily routines. There's some references for you. And just to say thank you very much. Again, thank you for the honor of speaking at LIBSS this year, and take care and stay safe. Thank you very much.
That's absolutely fantastic. Thank you very much, Yitzka. We're waiting for see if some questions come through. I can't see any from any of our delegates, so I'm going to kick off really. No, we do have a question. So there appears to be more demand on time, especially with an increase in online meetings and online conferences, not just in normal work hours, but out of hours. And how do you suppose that we could try to manage this?
Oh, just unmuted myself. Yeah, Mary, thank you so much for that. I think that is something we all need to negotiate. I think I agree, there's very much blurred lines. Personally, myself, I'm probably working 13, 14-hour days and probably another full day over the weekend. I think one of the things, I know some trusts and academic institutions have said sort of no online meetings on certain days, just to give a protected day. There's a policy in my university where all meetings end 5 minutes before the hour to allow people time to get up and stretch, have a cup of tea. I can't say I notice a difference in it, but I agree very much it's the volume. And I think because if, let's say, a face-to-face meeting is in place, and we would have to travel, you've almost got that recovery or that decompression time in between meetings, especially, in a hospital, you would walk, from one office to another, and that time that we just have to recharge. But I think I agree with you, it's just full on at the moment. And I think it's something we need to negotiate. And I think as opposed to just sort of being passive recipients and taking more meetings on, I think we need to think about that and challenge it and perhaps put it out in MDTs and in our academic and clinical practice and address it, because I think it is a problem, you know, personally, and I can speak for my colleagues as well, but thank you very much for that.
Thank you, Yitzka. And we've got a question from Manisha Sharma that's come through, which thanks a lot for an excellent talk and raising some burning issues. You touched on moral injury of not being able to look after patients face to face and not being able to examine them and make judicious clinical judgments. How do you propose we deal with that?
Yeah, I would think I'm really interested to see what Jane Ogden from a psychological perspective has to say about that. But no, thank you for that. That is something, again, it's happening. My colleagues and myself have experienced that, you know, for example, doing research where I'm used to speaking to people face to face, having them in front of me and having to do it by video and or telephone. I don't feel that connection's there. And often I feel sometimes that I could be failing them and I'm not. It's a very difficult thing, but, you know, there is that duality where I want to keep them safe. You know, I test myself regularly, but if I met somebody face to face and 2 days later they tested positive, I would feel really, really guilty about it. So I don't quite have the answer, but I think that's why I like the concept of moral injury, because I think it allows time to sort of reflect, and as opposed to just saying, well, I feel really guilty about this. Why do I feel guilty about it? What can I do? And I think also there's a thing about just, and here's a person with huge control issues, acknowledging that so much of this is not within our control and not to feel bad about it, but knowing that we're doing our best in a very sort of challenging, complex and ambiguous situation. I think just to be kind and forgive ourselves once in a while. But I would say also we need to keep talking, because I know I'm not the only one that feels like this. And judging from the comments, you know, I'm obviously not alone in this group too. But I just want, Jane, I don't want to put you on the spot, but obviously in your professional capacity, I just wonder whether you wanted to add anything.
I mean, I think exactly what you just said, really. I think the key to all of this is about being kind to ourselves and to others, really, and to you know, there's something about setting your standards high, but accepting that things are very, very difficult for everybody, the same as yourself and for everyone else, and that somehow patients need to be kind to themselves and to clinicians, and the same that, you know, clinicians need to be kind to themselves and patients, and it's just that recognition that we're all in it together, and it's just very difficult. And I suppose from an academic perspective, I think we have the same dynamic going on with our students as well, that anxieties are sky high all around, and that can lead to kind of real kind of conflicts, but just letting yourself off the hook, I guess, you know. And I think the same, you know, you say you have control issues, psychologists often have kind of control issues, and we need to be forgiving of ourselves and just do our best, I suppose.
Thank you.
Wonderful. That's absolutely fantastic. Thank you very much to everyone. So I'm going to hand over to the next chair, Sarah Ajaz.
So for the next talk, it is my pleasure to introduce Toni Jenkins. Toni is a nurse consultant. She trained as a nurse at Guy's Hospital in London in 1987, and then she trained as a midwife at St Mary's Hospital, Paddington. Toni works as a band trainer, having training in Lyon, Chicago, and New York City. Toni works very hard to improve the provision of services to support obesity issues within the UK and NHS, and she is frequently interviewed by LBC and BBC Radio. So it is my pleasure to invite Toni for her talk on family living with obesity. Over to you, Toni.
Thank you very much. My presentation is going to be the pre-recorded one because I've actually had a power cut here and I don't know if the Wi-Fi is going to last. So if I suddenly disappear, I will reappear again via my iPad. So I'll hand over to the techie people to put on my recording. So is it a challenge or is it a bonus? And I think that's something we need to consider. We all understand the risks and complications related to living with obesity. There's no dispute that there are physical challenges that include the obvious metabolic comorbidities and the weight-related cancers, the psychological disorders, etc. And there are certain psychological disorders that also include sort of behavioural issues, such as learned behaviours. You know, we learn how to do things according to how our parents are or how other family members are. Learned neuroses. If certain members of your family never eat vegetables, the chances are that you're never going to, because you may have develop the same sensitivities towards them. And also there's normalising of unusual eating practices that may seem strange to people outside of your family, but quite. And we often hear this said, you know, we're all big boned in our family. And this is actually a picture of me on the left and my late mother on the right. And we were both extremely overweight. And I come from a family where 5 of us had weight loss surgery. And there's no question that we were all big boned. But in fact, once we lost the adipose tissue, we realised that our bones were actually pretty much average size. But we all genuinely believed that it was just something that ran in our family. Now, there's a definite genetic predisposition, and there's no doubting that. There's plenty of research been done, particularly the work done by Stunkard et al. And 2 important pieces of research came out that said that identical twins almost always weighed the same, even when they were adopted and reared apart. Non-identical twins were usually similar in weight, but no more so than with their other siblings. There was a strong correlation between the BMIs of adult adoptees and their biological parents, but no correlation was seen between the BMI of adoptees and their adoptive parents. Now that's very interesting, because clearly there is an element of nurture, but it does show that nature seems to win hands down on this, and it's almost as if the dice is loaded against you from the start, regardless of what you do eating-wise, although we all know that there are various measures we can take to help our weight to get within a healthy range. So what can be done? Well, we know there's a strong genetic component, and that can't be denied. However, one of the things we do have to think about in any family is issues such as portion distortion, and what might be considered to be an average size portion in one family might be very large or very small in another. And you'll often get people saying, oh, we love this restaurant, you always get really huge portions. And often people will tell you they're like a restaurant because of the portions, like TGI Fridays. The portions are massive. And this may be a consideration for people, whereas other people like to have small volumes of very good quality food. Some people really feel that they need to feel full. Sedentary lifestyles tend to run in families. If everyone in your family gets up, rides a bicycle and is quite physically fit, the likelihood is that you're going to too. If dad gets up and plays, football with the kids in the garden, or mum, that may be normal to you. But if you come from a family where most people just sit and watch the TV, you're probably going to think that's normal behaviour. It's not to do with laziness, it's to do with normal practice, really. Now, there are certain economic issues related to food choices and availability, and we can't ignore those. I mean, cheaper foods are usually not so good for you. And even if you walk past a sort of South London fried chicken shop, even today I saw for £1.99 a chicken breast, some chips and a can of fizzy drink. Now, £1.99, there's very little you can buy for £1.99 that's healthy. And everybody will say, well, you can always buy a loaf, you can make sandwiches, etc. And that's very true. But you have to also consider where people live. And I think if you're living on a high rise in the middle of an estate where there's no supermarket nearby, the likelihood is you're going to go to the little local corner shop that's going to sort of be a jack of all trades, really, and try and please everybody. And generally the foods there are high in salt and saturated fats, and that's the kind of food you're going to eat. You don't often have one of these little corner shops in the middle of a estate selling beautiful fresh vegetables. And again, we have to think about what's people's knowledge of food. It's very easy to think that everybody understands the difference between a carbohydrate, a protein and a fat. But for many people, I've talked to patients in the past and they genuinely believe that the word protein meant healthy. So they'll say, oh, I eat plenty of protein. And when you ask them, they mean vegetables. They don't really understand the difference. To them, there's just good foods and there's bad foods. They don't seem to understand the nutritional differences. So there's the knowledge, there's the skills. Even if we were to provide a beautiful box of fresh fruit and vegetables and lean cuts of meat to a family every week, free on the NHS, do they actually know what to do with them? Do they know how to cook them? And moreover, do they have any facilities? there are many people out there that live with a microwave and nothing else. Or if you're living in substandard housing, you may not have access to a kitchen. If you're living in a hotel, for example, people that have been housed by the local authority, they might not even have access to a kitchen or a fridge. So we do need to think about that. You can't just assume that everybody has access. And there's also the issue, and I should imagine many people here will have experienced this, of people that are intentionally increasing their BMI so that they qualify for metabolic surgery in the future. Now, this is a very popular slide of Gary Larson's, and many of you would have seen it. But you know, the top of the slide, hey Ginger, don't do this, Ginger. And the person talking to the dog, well, he understands every word I say. But on the bottom, you've got what Ginger actually hears. And for many patients, they are so used to being criticised and challenged that they just hear their name and blah, 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 criticise, criticise. And so don't be at all surprised if patients aren't really listening to you initially. So psychological barriers, well, fear of judgment and criticism. Most people living with obesity have faced criticism for a very long time. Every time they go to the GP, the issue of their weight is raised. And you know, that can actually keep people going off to the GP with symptoms of all sorts of nasty illnesses because they're frightened of being criticised for being overweight. And healthcare professionals haven't helped in the past. Many, many times I see on international fora the word recidivist or recidivism used with relation to weight loss surgery. Now, I'm not just saying this as a patient, but as a clinician, I find that word deeply, deeply offensive and unacceptable, and I'll cover that more on the next slide. Also, there's elements of secret eating and hiding food, and this is very common if you come in a family of big people. People often eat secretly. They don't want to be judged for it, but they don't want to share. Now, when we look at terminology, I looked up the word recidivism and recidivist in 3 different dictionaries. And the first one came up with a convicted criminal who reoffends repeatedly. Cambridge English Dictionary said a criminal who continues to commit crimes even after they've been punished. And the Oxford English Dictionary said a person who commits crimes and seems unable to stop. Now, those terms, without question, are to do with criminals and bad acts. And to use those with relation to obesity is frankly shocking. And I'm absolutely astonished that people are still able to use it. It's completely unacceptable. Patients are not criminals. Patients will generally lose weight and regain because we are genetically predisposed to regain weight again. That's why weight loss surgery has such a role. And I think to accuse patients as being stupid or bad is really very shocking. So prevention, well, most patients don't really want the truth. They just want a constant reassurance that what they believe is the truth. So, you know, one week in the newspaper it says that tea's bad, another week it's good for you. So there's constant rumours going on about what foods are good and bad. And I think people tend to cling on to the ones they like the best. People were very keen on Atkins initially because it meant that they could have a fried breakfast. And people still hang on to that. Nobody really likes the idea of a low-fat diet because it's not nice. So the truth, the whole truth. I think that I'm not suggesting that patients lie, but I think that many things that patients say or don't say are related to the response that they expect to receive following what they've said to us. So I think patients will often have selective recall of events or what they've been eating in particular. People will often say, and they'll be endorsed by their family members, I don't eat anything all day. I just have one meal in the evening. I don't understand why I'm overweight. But their idea of not eating all day may not take into account the pretzels that are constantly on their desk, or the fact that they snack all day long off other people's desks, the fact that they're constantly in the coffee shops getting the choco mocha lattes and the drinks with the syrup, some of which could be 600 calories or more. And they will justify it. They'll say, I have fruit juice and smoothies, which are very sugar laden, because it's fruit, it's fresh fruit, it's very healthy, it's part of my 5 a day. And they'll justify having milky drinks in the coffee shop because it's calcium and it's really good for my bones. And they genuinely believe it. So I don't want to burst their bubble, but they need to understand that these are calories eaten, even though they may not be food. And I often say to people, you want your money's worth out of calories. You want to actually feel that you've had those calories. So don't waste them on things like that. They may well give edited accounts of what they're eating and their exercise, but that's not because they're lazy and they're liars. They don't want to be criticised. They may well have been coached of what to say or what not to say to a healthcare professional, and that's very common in weight loss support groups on places like Facebook, particularly when they want a particular operation. oh, don't say that you're a sweet eater, they won't like that. Don't say that you graze, say you eat portions. Don't say this, don't say this. For God's sake, don't say you've got reflux. Don't mention these psychological problems, because they genuinely think that they're not going to get the operation that they want. And they may be scared, to be completely honest, in case they disqualify themselves from surgery. So we say expecting things to change without putting any effort is like waiting for a ship at the airport. Being overweight is unfair. It's not fair that there are people out there that can eat what they like, but unfortunately life is unfair. And so we have to make the most of the cards we're dealt. So there may be genetic factors fighting against us, but the only way that we are going to have any say in our body habitus is to make some changes. Now, that doesn't mean you have to live like a nun and give up everything good, but you have to make some changes, and they have to understand that. And that may be difficult if they're a member of a larger family, because you get the situation where everybody's encouraging you and they want you to do well, but they actually don't really, because you might do well and leave them behind. And it almost goes back to the old cliche of the working class blue collar worker with the first child in the family goes to university, and instead of being congratulated, their family don't like them because they feel that they're elevating themselves out of their social group. And this may well happen. Any of you that are watching the 600-pound sisters on TLC at the moment will see that one sister's very keen to get her weight loss surgery and make changes, and the other one isn't. And the one that isn't is really holding back the other one because she's frightened of being left behind. I don't think she wants to wish her sister bad, but she's scared of being left behind. It's so much easier to be overweight when you've got other people being overweight around you. So, clinical and ethical concerns for healthcare professionals. So, family members attend that are also living with obesity. That's not always such a bad thing, but it's something we need to be aware of, because we need to think, are they eating the same kind of foods? Are they going to encourage each other to sort of break the rules, so to speak? Another more concerning issue is the child living with obesity. Now, it may be that we've got a child that's just a little bit overweight and we need to keep an eye on them. But if you have a child that's significantly overweight, this is a big ethical dilemma for nurses and healthcare professionals, because part of us, there's a safeguarding issue where we think this child really needs some support, and it may be that rather than reporting them to a safeguarding team, you actually try and raise the subject with them and see if you can encourage ideas about healthier eating. But you have to be a little bit careful, and I don't blame these patients, because there's been so many rumours in the past about children being taken into care and that it's child abuse if your child's overweight. But I think it's almost better to engage them all in the conversation and say, you know, if one of you has a procedure and one of you starts to get new eating habits, it might affect all of you and it will all do really well together. You have to consider issues to do with abuse. There's the obvious sexual and the physical abuse, but also constant teasing. And particularly if that patient is a member of a very close family where the other members are not living with obesity, where they may think it's okay and it's banter to constantly tease them about their weight, but it doesn't really help. There are clearest economical issues about, will that person be able to afford their healthier diet after their surgery? Will they be able to afford the vitamins, which may well not be available on the NHS? And cognition, do they actually understand what you're talking about? And it's very easy to nod in all the right places, but they often don't understand. So, do we work with the patient or do we work with the whole family? Well, clearly that's a matter of consent, and we need to talk to that patient and say, how do you want us to play this? Do we encourage the partner to attend? I certainly think it's worth having a partner to attend to talk about diet and the sort of foods they might want to be getting into the house. But that patient really has to be on board with this one. And also, is that family member going to be a support, or are they going to be a spy? There are trust issues there, and I've certainly felt very uncomfortable in the past where I've been talking to a patient that's been describing their diet, and their relative looks up at them and said, that's not true. You ate ice cream the other day. And whilst we might all think it's a bit funny, it's not really how it should be. And I find that quite difficult. So we almost have to have some ground rules, really. Recognised experts over time. Well, unfortunately, we all think that patients listen to us, but they don't really. Facebook is far more powerful. We need to be mindful of that. So the advantages of being in a large family: you may get tolerance, you may get empathy, you may have more understanding, you may not get judgment, and it may be a safe space, but equally it may not. So finally, my take-home message is, you need to have excellent and very clear communication. You need to engage with the family if the patient agrees, welcome the family members and offer support if possible and appropriate, encourage talking therapies, and most of all, be kind. Thank you very much.
So patients are not criminals, and they just want reassurance that what they believe in is the truth. Tony, that was a brilliant talk. Thank you very much. So let's look at the questions. Right, so some very interesting questions for you, Tony. The first one is from Mary O'Kane. What can we do differently as HCPs to help develop the rapport with patients living with obesity and encourage a safe environment for them to be open and help them to move forward? Tony.
Yeah, this may be easier said than done, but I do think that in many hospitals, before you even have weight loss surgery, you have to come along to a patient support group. And I think that's quite useful because it's not really a clinical setting. It's more chatty, friendly, feely, touchy-feely stuff. And I think that we have to obviously consider whether or not the resources are there. But I do think our first couple of consultations with the patient should be more to do with engaging with them and being friendly, rather than actually saying, well, I'm here to discuss your eating and I'm here to discuss your health. I think if we can just let them realize that we're actually quite nice people and our main aim is to help them. I do genuinely feel, and this has probably been compounded by us having tier 3 forced upon us, that for many patients, they feel that it's yet another hurdle over which they have to jump. And so they almost feel that they have to sort of smart talk us to get us to support them. And I think if we can just find a way of getting across to them that we actually are there for them, we want them to get treatment, we want them to get surgery. Our main aim is to make sure they get the right procedure for them and that we're going to help them through it so they get the best outcomes. Our main aim is not to stop them getting what they want. And so I think that probably the easiest way of doing that is in the support group where you're not actually sitting at a desk. So I think engagement with them, or even, and this is one of the advantages of COVID, where particularly with vaccinations, you know, we've got health and wellbeing buses going into the community, and often people can come along and just chat with you about all sorts of health problems. And so I think if we can make ourselves more accessible, perhaps have a stall in the local shopping centre once a month on general health issues, just so that we become not so untouchable to them, if that makes sense.
Thanks, Tony. So the next question, well, first a suggestion and then a question by Yitzka. So Yitzka says, Tony, you are so right about terminology leading to labels, but what resonated with me is the fear that people living with obesity have about being stigmatized when seeking help. Any suggestions for making patients feel comfortable in healthcare encounters?
Well, I think that's going to take a long time, you know, because people inherit those bad feelings about healthcare professionals from their parents and their families. So I think this is something that's going to change over a generation. It's not going to happen anytime soon. But I think just making sure it's getting slightly easier because as healthcare professionals are training now, there's an emphasis on communication and using patient-first language so that we've got people qualifying now that are less likely to use the old terminology. But there are still people out there that use it. And a lot of them are people that really care about patients and they wouldn't intend at all to upset people, but they just use these terms. I've heard doctors say things to patients in quite a jokey way, and they mean it to be kind, like, you're a bit of a porker, aren't you? Or you're a bit hefty. And they think by using a kind of a little jokey term that it somehow stings less, but it doesn't. So I think it's just reminding people constantly that we have to understand that, you know, we've inherited a lot of bad feeling that's been caused by, you know, the generation ahead of us. There are lots of really unkind things said that people just need to change on. I mean, I can, those of you that follow me on Twitter will recall when I was a student nurse, I looked after a lady who had gone for a cervical smear test and she was in her early 30s. And the nurse that did her smear test had complained that she couldn't visualize the cervix because there was so much fat in the vagina. And she just said to her, this is really difficult. Don't come back until you've lost the weight. So this patient didn't come back. And my first contact with her was when she came into the ward via A&E with severe abdominal pain and had severe and extensive cancer. And she had never gone back for another smear because she felt that she was making the nurse's life difficult and that she was a nuisance. Now, that's a very extreme example, but that woman died of embarrassment. She literally died of embarrassment. And I attended her funeral. I think she was 32 the day she died. So these little remarks make all the difference.
Well, thank you very much, Tony. We have got some more questions, but we are pressed for time, so we'll just have to move on. So I will ask Dr. Manisha Sharma to introduce our next speaker. Thank you.
Hello, thank you, Sarah. I have the privilege to introduce Professor Jane Ogden, who doesn't need an introduction. Professor Ogden is a professor in health and psychology at University of Surrey from 2005. And she was a reader in health psychology in King's College London prior to that. She has been researching in writing about eating behavior and weight management for almost 30 years. And her research interests are women health and communication. She's a frequent contributor to magazines, radio and television, including Secret Eaters and The Truth About Fat in Channel 4. She has written several textbooks, including a textbook on psychology. And she's also the program leader of PhD psychology course. Over to you, Professor Ogden. Thank you.
Thank you very much, Manisha. That's great. Hopefully you can see my screen. Is that okay? You can see me and you can see my screen. Brilliant. Well, thanks everybody, and thank you for inviting me to talk today. I've been having lots of thoughts over the last couple of years about an issue which I'm struggling with and haven't found any solutions to at all. But I thought today I'll try and talk about that and perhaps generate some kind of discussion and perhaps kind of clarify my own thoughts and just kind of put it out there a bit, really. So my talk today is about finding the balance between choice, responsibility and empowerment, and blame and guilt. And it's clearly a big conversation, but let me see how we get on with it. So my current dilemma as a psychologist and as somebody who's, who has a kind of strong sense of the importance of health is that the evidence out there is incredibly strong for the benefits of being active and eating well, and the negative consequences of sedentary lifestyles and having a poor diet. And that's regardless of body weight, but it's incredibly clear that the more active you are, then that has a benefit for a whole range of health conditions, whether it's cancer or heart disease or diabetes, and that eating well has the same kind of benefits. So as a psychologist, my dilemma is that we want to encourage better behavioural choices in everybody, regardless of whether of body weight or not. But how do we encourage people to make better choices around being active and eating well, and encourage a sense of empowerment and responsibility for those choices, but without then having the downsides of feeling blame and feeling guilt when things don't necessarily go as planned? And exactly as we've just heard from Tony, there's a huge amount of stigma out there, a huge amount of criticism, a huge amount of negativity to people living with obesity. And that's because they experience the blame and the guilt for being perceived not making those positive choices. So how do we go about getting that balance when people can feel that they have choice, but without having the downside? So what I thought I'd do today is just to give a brief history of the notion of choice, and then how that's been reflected in the literature, and then what's been happening recently within the obesity community, and then again to kind of outline my dilemma in my own thinking, and how I haven't kind of worked this out yet, to give you my personal take, and then to finally reflect that there is no data on this, because I think there cannot be, but we need to kind of develop a position. So this is a really broad brushstroke of hundreds and hundreds of years of human beings and research, but it's a very brief history of choice. So my brief history of choice. So pre-scientific revolution and pre the kind of days of evidence-based research or trying to look for observation or trying to understand the world, then we were dominated from a religious perspective when I suppose God and many, many different types of gods were in charge. And then along came the scientific revolution, which emphasized the notion of things being evidence-based, of using observations, of being able to understand the world, of doing studies, of testing hypotheses, and carrying out research. And then after the scientific revolution, we had a kind of number of perspectives which emphasized who we were and where we came from. So we had the role of Marx, who emphasized the role of social class. We had Darwin, who came along and emphasized the role of biology. We had Freud, who came along, who emphasized the role of the id. We had Skinner, who came along and talked about beyond freedom and dignity. And then we had Bandura, and these are psychologists and sociologists, but they frame our thinking of the world. And Bandura came along and talked about socialization. And that kind of model of the individual, which happened pre and post the scientific revolution, was very much about the individual being someone who was a subject to their fate or their destiny. They had no agency, no free will. It was about biological reductionism, or it was about social reductionism or socialization. And people were a product of their genes, of their class, or of their past. So within a kind of, a deterministic perspective, we were who we were because that was given to us by our biological makeup or our social situation or our history. And within health and health research, that took on the form of medicalization. So problems such as whether it was obesity or whether it was diabetes or heart disease, whether it was addictions or whether it was mental health, depression, anxiety, schizophrenia, we had a kind of medicalization process. And we talked about the disease model of addictions, where people were addicted to the drug or had addictive personalities. A medical model of mental health, where depression is seen as being a medical imbalance or anxiety is a product of higher levels of arousal. And that perspective really emphasized our biological reductionism, or it emphasized our socialization. And I suppose cutting across that was really about kind of accident. We are a product of what's happened to us, a kind of accident of birth. And that really was about determinism and having, no choice. So human beings weren't really conceptualized as those as having choice. And then from my perspective, and I guess this is my discipline, there was a brief window from about the 1960s where there was a kind of sudden emphasis that we need to think about people as having a bit more agency. And the kind of classic names at this time, if you like, were kind of Thomas Sachs, who wrote about the myth of mental illness and differentiated between people being mad or people being bad. We had the anti-psychiatry movement with R.D. Laing or with Foucault, who was very critical of medicalization. We had Ivan Illich talking about iatrogenesis and the problems of over-medicalizing conditions and how that could lead to unintended consequences or unintended harm. Within the addiction world, we talked about dependency rather than addiction. And then within psychology, we had things like Maslow and self-actualization. And that kind of shift in emphasis was part and parcel of a kind of a political shift or a shift in the way we see the individual. And some of that, the politics wasn't particularly something that I would necessarily kind of adhere with or was particularly impressed by. But that was a time of individualism, notions of freedom. We had in the UK, we had Thatcher and her notions of the self-made person and that we could be whatever we wanted to be. And also kind of movements towards libertarianism, I suppose. And so there was a window by which the individual had some sense of empowerment or responsibility. And within psychology, there's a huge amount of literature around decision-making, how people make decisions, what their cognitive processes are, what their sense of agency is when they're making those decisions. And that was very much around choice. So people make choices, and the research looked at how do people make choices, how having choice was good for the individual because it made them feel in control. And we know that perceptions of control are good for sense of stress, for sense of well-being, for mental health, for physical well-being. Being in control, having choice is seen as a kind of positive factor in people's well-being. And so there was this kind of brief window, if you like, when this very much came out in the literature. And that's how we started to see people. And that's where I suppose psychology kind of suddenly kind of blossomed, really. So we are ultimately the study of the individual, I suppose. And we situate the individual within their social context. and we understand the role of biology, or we understand the role of social structures, whether it be poverty or social class. But ultimately, there is a sense of the individual making choices and having some sort of sense of agency. And then what seems to have happened recently is that's kind of getting lost, I suppose. And again, there's been a kind of rise of medicalisation, and we hear very much around disease and medical models of mental health and physical health. So, the data on twin studies is very much cited. Again, medical models of disease are very much the focus. We have medical solutions, medical ideas of causality, and also of consequences, and then also of treatment. And genetics is on the rise with the Human Genome Project, and neuroscience and research on the brain, and the focus on the brain is again on the rise by looking at MRI studies and understanding the impact of the brain on the ways in which we behave. And so it feels like we're slipping back to a kind of sense of determinism, really, where people are losing the focus on having choice, or having a sense of being able to make their own decisions. And I suppose what I've kind of felt that I've been watching over the last decade or so is that this shift back to medicalisation has been adopted by the obesity community. And I can understand kind of why that is, because that's very much, there's been a focus more on biology and genes, and a move away from choice, empowerment and psychology. And that's very clearly come out of the problems with the downside of choice, which is around guilt, very much around stigma, not wanting to stigmatise individuals, absolutely recognising that people living with obesity are stigmatised and feel that stigma. And a medicalised model of that is a way of relieving that stigma, of helping with that stigma, and wanting to get away from issues of blame and all the things that we've been hearing from Tony, which I thought was absolutely fabulous, about how that exists within families, how that exists within the interaction with healthcare professionals, and that kind of inheritance, if you like, of a sense of stigma, inheritance of a sense of blame that's come throughout the culture surrounding obesity for such a long time, and a sense of responsibility. So what's happened within the obesity community was there was a lot of negativity around people living with obesity that was perceived by those people, experienced by those people living with obesity, and also became ingrained in the language of the healthcare professional consultation and the ways in which they were talking to people living with obesity, and also in the wider world, in the media, in the images that we see, those stigmatized images which are out there. Whenever you see any newspaper article on obesity, the person has no head, or whenever you see anything on social media, the person living with obesity is always eating a burger. And because of those stigma and those stigmatized imagery and that stigmatized communication, then the solution to that has been seen as to move away from the guilt, stigma, blame and responsibility. But at the same time, that's been a shift away from feelings of having choice. So my sort of current dilemma really is that because the evidence on sedentary lifestyles and poor diets is so huge, and because the importance of eating well and being active is so clear, we still need to encourage people to make better choices, regardless of weight, but particularly for those living with obesity. But we need to encourage people to make better choices, to be active and eating well for everyone, but then we don't need to have the downside to that as well. And so it's about perpetuating a model whereby individuals feel that they have choice, but they don't have the blame and the guilt that go with that. And I suppose it's about trying to work out how we can undemonize the notion of choice. And so I often see, it is not a choice what people are doing, and I can see why that's the case. We're telling people that it's not a choice, but feeling that you have no choice isn't good for well-being. And there is a literature which shows the perception of choice, the perception of control, is good for reducing stress and anxiety and increasing senses of well-being. So this is my take, which may or may not be of any use, but this is how I kind of work out how we navigate our way through this kind of literature and navigate the perceptions that we're giving to people, is that we're at crossroads and we're kind of at crossroads at any particular time. And at those crossroads, we have our past, which drives us to a particular time, and then we have choices to make at those times when we reach those crossroads. So my answer is that our past makes us what we are, but we can choose some of our future. And I think in line with what other people are talking, particularly what Yitzka was talking about, and also with Tony, was that when it goes well, we need to celebrate having made the right choices. But when it goes wrong, then we need to emphasize being kind and self-compassion to deal with issues of guilt and blame, whilst at the same time we still need to carry on emphasizing that choice is an important thing and that we can believe in it. So I suppose my take is that we don't know whether people make choices or not, and we don't know whether people are biologically determined or not, but we know that choice, and it might be a myth, but it's ultimately what makes us feel human. And the reason I have no data, as much as I've struggled with this for quite a long time, trying to work out how to do a study on choice, choice isn't an empirical question. Ultimately, it's a kind of ideological position, but believing in it, regardless of whether it's or a myth, can be a good thing for people. So we need to work out a way of doing that without actually demonizing people. So I would really just like to enter into some sort of discussion about that, rather than necessarily having any conclusions. So thank you very much.
Thank you very much, Professor Ogden. What an excellent and heart-touching chat. I'm speechless. That's why I'm struggling. Yes, you are absolutely right. We, treating patients as human and understanding the human side of somebody who is behind that diseased, obese body. Like you said, for the discussion, are there any questions? Otherwise, I have a question. So there is a question which says, how can we bring, thanks for a really good talk, how can we bring the element of choice into the consultation without it sounding judgy?
Well, as I have said, I'm not sure I really have any answers, and that's what I was kind of trying to do. But I think it's about understanding that if things go wrong, then you're not judging for having not done it, but you then celebrate the things that you have done. So it's a way of switching it round so that it can be kind of very kind of positive, that you have succeeded in this, this, and this, and you have. These are the good things about you, and this is what you have done well in your life. And now you consider doing something a bit different. But people have always achieved so much. And I think that's the context. It's going back to what Tony was saying. It's starting those conversations in a positive, affirming sort of way and being friendly. And I think exactly actually what Tony said about starting consultations just by getting to know each other and just by smiling and just by nodding and just being warm rather than being critical. And that's a kind of fabulous way of starting. And then when you start from that, then you can start putting out alternatives. But people need to feel that there are alternatives without being then criticised for not necessarily doing them, because they're always doing something which is good. So it's very much about taking the positive kind of perspective. I've seen Tony just come onto the screen again there. I don't know whether you want to contribute to that at all. Or you're on mute.
I agree with everything you say, really. I think the difficulty, somebody had mentioned this earlier about people that the people that are self-selective come to see us, and it's what about the people that are at home that don't get any care and how we engage with them. I don't know what the answer is there, but I think we need to almost go out into the community, but that's very easy to say and not so easy to do. So perhaps this is something we all need to get together and put our heads together and see if we can come up with a plan.
Yeah. It has to be about kindness, doesn't it? It has to, the whole thing has to be about kind of self-compassion, other compassion, being kind, being nice. It's all really basic stuff, really. I think, lots of the literature on the consultation is about, the details of what people do. But I think, what's important around that is just being nice to people. And that's awful to say, but, it is about being nice to people and feeling that people are being listened to, and that you're not judgy. You're actually just there trying to help. And that's about building it up in a positive way before. Oh, wow, that's a big question, Yitzka. Do you think shall I read it out where people can see the questions? Do you think these thought processes have been affected by the pandemic? Have we become nastier as a society? Do we become nastier? I think we've all become a bit more stressed and a bit more anxious. And I think the more anxious you are as an individual, probably the less you've got to give to other people. So I think, in a way, I mean, this is, I don't think I have evidence for this, but kindness comes from a position of positivity about yourself. And I notice that, the more, when I work in an academic setting, so the more stressed people around me are, the more they're inward looking and just managing themselves rather than being able to being kind to other people, because they're too caught up in their own emotional regulation really to take on the problems of other people. So they might well then become more judgmental.
Yeah.
Thank you so much, Professor Ogden.
You're very welcome.
And I think that we are short of time, so I will have to ask my question personally on a different platform later on.
Yeah. No, send me an email,
that's
so fine. Yeah.
Thank you so much.
Okay.
And I will pass on the baton to the next chair for the next speaker, please.
Okay. I'm Mary O'Kane, and I've got great pleasure in introducing the next speaker, who's Dr. Stephanie Atterley-Smith, and she will be presenting on reproductive health and bariatric surgery, and her bio is available on the platform.
Thank you very much. Hopefully my slides have appeared and everyone can hear me okay. Yes, a slight change of focus now from the previous talks, but I wanted to talk about female fertility and contraception after bariatric surgery. I'm an obstetrics and gynecology doctor, so this is obviously my area. So over the next 15 minutes, I was just going to go briefly through the return of fertility versus advice regarding optimum time for conception, that I believe there to be a real unmet need for contraception in women undergoing bariatric surgery. Just looking at contraceptive safety in this cohort, and then really just going through the headlines of the different methods, hopefully giving people a little bit more confidence to bring the topic up and know just the gist of some of the methods. So in terms of fertility after surgery, we see that fertility does come back very quickly after surgery, and studies have shown that if you have polycystic ovarian syndrome, which is linked to obesity, if you lose 5% of your body weight, then you might start ovulating again. And a study conducted recently on women with polycystic ovarian syndrome having surgery showed that their menstrual cycles had regulated within 3 months of surgery, and having a regular menstrual cycle is a way of demonstrating that you are ovulating, because you require ovulation to trigger menstruation. So fertility is likely to return very quickly after surgery. However, the advice regarding having a healthy pregnancy with the best outcome for you and for the baby is to delay conception. Now, the advice, depending on where you're drawing your advice from, is quite variable. I think we are moving to believing that weight stabilisation is the much more important factor than any absolute timeframes. But at the moment, we do say waiting at least 12 months after surgery and waiting until your weight is stabilised. But you will see in some reference material that they suggest waiting at 2 years as a minimum. So thinking about pregnancy after bariatric surgery, there is now lots of information in the literature to suggest that this is safe. And actually, if we look at it compared to conception in and pregnancy in obese women, a lot of the risks are ameliorated from the surgery. So in terms of antenatal risks for women with obesity, so there is increased rates of gestational diabetes, of hypertension, of preeclampsia, and essentially these all reduce with the weight loss associated with surgery. And go back to your sort of background risk based on your BMI at the time of conception and any other relative sort of health conditions that you're going into pregnancy with. The only thing I've just flagged up here is about internal hernia. So abdominal pain is not an uncommon symptom in pregnant women, and there is a sort of tendency to avoid investigations and avoid treatments in pregnant women, and this has led to some problems with internal hernias being missed or diagnosis being delayed. So that's sort of a new problem that is potentially brought up through surgery. Obese women having going into labour and having their delivery have a lot of additional risks. They tend to not labour so well, so end up with assisted deliveries and caesarean sections. They also often end up with more bleeding and more post-delivery complications such as infections and thromboembolism, and the weight loss from surgery again reduces all these risks. And then finally, in terms of the baby, women with obesity have higher rates of miscarriage, stillbirth, neonatal unit admission and neonatal death, and all these risks appear to be reduced with weight loss. The only, again, little star I've put in there is about nutrient deficiencies, perhaps predisposing to growth restrictions of babies. Again, this sort of link to weight stabilization before surgery and optimizing nutrition, before pregnancy, and optimizing nutrition prior to pregnancy should help to minimize the risks of growth restriction. So undertaking pregnancy in a planned way is obviously of great benefit to that. So sorry, slide's taking a little moment to load. So just to say, this is a snapshot from the Faculty of Sexual and Reproductive Health, and they have recently added bariatric surgery to their list of procedures that could cause a significant health risk in pregnancy. And as you can see here, they have 2 years as an absolute time frame, which, as I say, is sort of not really the latest guidance on that. So I am in the process of doing an MD and looking at reproductive health in women having surgery. It's been a very protracted MD with the pandemic stopping it for quite a long time. But anyway, a little bit of my data just to, I think, reinforce some of the things that I'm saying. So we asked 80 women prior to surgery what their motivation for surgery was, and the overwhelming majority were doing it for health reasons, or at least that's what they reported. But you can see a significant number were doing it to help them get pregnant. So this is something that people know is helpful in terms of pregnancy, and often, the delays in getting surgery, they are quite desperate to get pregnant. So you can understand why they might not be keen on the delays that we are suggesting to them. In terms of contraception use prior to bariatric surgery, again, this same cohort of 80 women, and you can see that over a third of them were using no contraception, and if we include condoms in no contraception, which is possibly a little bit harsh, but it's not a particularly reliable method, then over 50% of the women having surgery didn't have a reliable method in place prior to surgery. And then just stratifying that in terms of their desire to get pregnant. And interestingly, I think not surprising that people who wanted to get pregnant were less likely to have these longer term methods in place, but actually people who were very clear that they did not want a pregnancy still didn't see the importance of contraception prior to surgery. So just a quick slide on safety. This is part of the UK MEC, so it's the UK Medical Eligibility Criteria for Contraception. And it basically is this very comprehensive document released by the Faculty of Sexual and Reproductive Health, which will go through lots of demographics, lots of medical conditions, and tell you whether different contraceptive methods are safe in those individuals living with those conditions. And they have now put a section of bariatric surgery in there. And as you can see, the issue is not around the surgery, it is around the BMI of the individual. So women who have a BMI above 35 after surgery or are in the process of getting to their final weight, then it wouldn't be safe for them to have combined methods. So this is the combined oral contraceptive. There is also combined patches and vaginal rings. So and that's all to do with risk of blood clots and stroke. But all other methods are unrestricted. And if women after surgery have a BMI less than 35, then they can use these methods. So a number 2 on this little scoring system means that the benefit of using the method generally outweighs any risks of it. 1 means it's completely unrestricted, and 3 means the risks are likely to outweigh the benefits. So it's just that cohort that have a BMI above 35 that need to avoid combined methods. Sorry, can't move on. There we go. So just a quick slide on types of contraception. So you might be familiar with the term LARC, which stands for long-acting reversible contraception. This is what we love in gynecology. This is basically an umbrella term for the contraceptive implant and the 2 types of coil. They are really effective methods and they last a long time, but once they're removed, your fertility returns immediately. So hence the long-acting reversible. The reason that they're, or one of the reasons they're so effective is because they're not user dependent and they don't need any action to be taken around the time of sex. The downsides of them is that they do need someone trained to fit them and to remove them. And then just a little extra bit about oral contraceptives. So there has been concern in the scientific community about absorption of oral contraceptives after surgery, but actually there isn't any evidence to say that they are less effective. And similarly, if you look at studies in inflammatory bowel disease and other people who have sort of potentially have malabsorption, this doesn't seem to be borne out in practice, but is something worth bearing in mind, and particularly if people are experiencing a lot of diarrhea and vomiting over a prolonged period of time, then perhaps oral methods are not such a reliable choice for them. So just trying to give you a few headlines. I think you could go through the pros and cons of contraception for hours, but so the combined methods are, as I have mentioned, you've got the pills, the patch and the vaginal ring. In the UK, it only really seems to be the pills that are used on a regular basis. This is the method that has the longest list of safety considerations. So as we've already discussed, weight, but also age, blood pressure, smoking, history of migraine. There's lots of reasons why this might not be a safe method for a woman. The benefits of it and why people like it is because it's the method that gives you the most predictable bleeding pattern, and you can have tailored regimes where you run pill packets together and essentially avoid having periods if you want to. And there are quite a lot of non-contraceptive benefits. One which is relevant to people with polycystic ovarian syndrome is that it improves acne. Progesterone only pills, so the other type of pills, there's no estrogen in this, that being the difference between the combined and the progesterone only. It's really safe, but basically the 2 reasons not to have it are breast cancer or disseminated liver disease. So probably unlikely in the women you're seeing. It can be a problem, irregular bleeding can be a problem with it. And it used to be a real issue because the older types, you had a 3-hour window every day to take your pill in. And if you missed that window, then its effectiveness really dropped off, but actually the newer versions give you a 12-hour window. And again, you might be aware that it's now available over the counter. So the negative aspect of this is that you pay for it if you bought it over the counter, whereas contraception is provided free, but it does improve access for people. The Depo-Provera is the injection. It's an injection into the muscle, normally into the buttock, and it's every 13 weeks. There is a wider window in which you can give an early injection or go slightly over the 13 weeks and still be protected. Often people stop getting periods altogether with prolonged use of this. It's the only method out there where there is some evidence that your fertility takes a little while to come back after stopping, and in some cases it's up to a year. So again, if people are desiring pregnancy after surgery, it might not be the best choice. Also potentially not the best choice because it is the only form of contraception that is linked to weight gain. And this primarily affects young people and those who have a raised BMI when they start the method. A quick note on weight gain, as it's highly relevant to today. As I say, this is the only method that has a direct link to weight gain. A lot of contraceptive methods can make you feel more hungry, and then if you act upon that and choose high calorie foods to sate that hunger, then obviously you will end up with weight gain, but there's not a direct cause and effect leading to weight gain, if that makes sense. The other potential issue about the injection in people with bariatric surgery is that it does reduce bone mineral density. And obviously, if we're concerned they might not be absorbing calcium and could be at risk of osteoporosis, osteopenia anyway, it might not be the best choice. The evidence says that your bone density recovers after stopping the method. It's a really good choice if people are on anti-epileptics because it doesn't interfere with them at all, whereas some of the other methods would. So I'm trying to speed up because I think I'm probably taking too long. The implant is a little rod that goes into the upper arm. It lasts for 3 years. It is the most effective form of contraception out there. It's better than sterilisation in stopping pregnancy. I think it's sometimes not understood very well is that even though it's in the arm, it is metabolized via the liver, so it can interact with other drugs. So you do have to be careful. And again, that's the anti-epileptics typically, and unpredictable bleeding patterns. So, people can not have a period for months and months and months, and then suddenly start bleeding a little bit every day. It's just completely erratic for some people. And that is the most common reason people stop the implant. The IUS, so one of the coils, so this is the one with the hormone in it, and there's various brands. I think Mirena is probably the most well-known. There's been quite a lot of attention on coil fits in the media recently. Most people tolerate it really well, but for some it is very painful, and you can get a sort of a bradycardia and a hypotensive episode from cervical shock. So it can be very difficult for some women. There are some risks because you're introducing a foreign body, so you can introduce infection. You can push the coil too far and make a hole in the womb, and also the body can just push it out again. You can have severe cramping pain, and the coil can be sort of pushed out of the uterus. Assuming you don't run into any of those problems, again, it's very effective, and it works by thinning the lining of the womb, so people get periods become much lighter, and lots of people stop having periods altogether. It has, again, other sort of non-contraceptive benefits, and it can be used as a treatment for heavy periods and a treatment for endometriosis. And also, if people are perimenopausal, it can be used for contraception and then carry them through the menopause and be used as part of HRT. The last one is the copper coil. So this has no hormones at all, which is its sort of real selling point. It's depending on how much copper it's got on it, whether it's on the little stalk or on the arms as well. It lasts for 5 to 10 years. There's no hormones, there's no drug interactions. The same considerations exist in terms of the fitting as the IUS. It's the same technique. Because it works through sort of a foreign body effect and a sort of slight irritation really to the lining of the womb, it tends to make people's periods a bit heavier, and because they're a bit heavier, they're more painful. So not great if people are already experiencing heavy periods. That wouldn't be a good choice for them. Fine, so that's my kind of headlines for those methods. In terms of what you do in practice, so the GP and sexual health clinics are the easiest places to access contraception, particularly with the fact that progesterone-only pill is now available over the counter. Pharmacists could be a very useful resource, and the other thing pharmacists are very useful for is emergency contraception. It would be lovely to think that bariatric services and gynecology services could link up and we could help, but I don't think that is a reality in many places at the moment, at least. And in terms of patients going on to, or women going on to making choices for themselves, there's two really great websites that I've just put up the links to there, and it talks to people about what do they want from their contraception, what are their priorities, and then sort of leads them through to a couple of suggestions that would be worth them looking into in more detail. So I think they're very, very useful, very user-friendly. Final slide is acknowledgement. So as I say, I've been doing this MD part-time for a very long time, and these are all my lovely supervisors who've been with me all the way through, and the bariatric centre staff at St Richard's Hospital who've been amazingly supportive. So just a big thank you to everyone, and I'm done. So any questions, I'd be very happy to attempt to answer them.
So thank you very much for an excellent presentation. One of the questions I have, and it's as a dietitian, and it's discussions I never thought I'd be having in clinic, is that patients, as you mentioned, that women have been struggling with fertility, they don't believe that they will get pregnant even after surgery. So they haven't started that discussion about contraception, and obviously I'm not an expert in this area, but I feel it's a conversation we need to have. How do we sort of get across the message that contraception is important, but also it is, and I think it's really interesting how you went through the different types. I just wonder if there's maybe certain types of contraception we could maybe recommend which go better with certain types of surgery, and maybe the malabsorptive ones is when we don't use oral. So whether or not there's sort of a non-experts guide that we can actually then give to patients, and then get them to go then and talk to their sexual health clinic, the GP or whoever, to talk further about contraception.
Yeah, absolutely. So I think your point about people recognising the need is really relevant, because you know, a lot of the women that I've come into contact with through my study just you know, haven't used contraception for 10-15 years and have never had a pregnancy. So trying to explain to them that actually this is potentially a reality for you in a few months' time, it just doesn't seem to sink in for some people. So I think the more of us that can mention it, and the more time women hear it, hopefully they might believe us, and they might be convinced to take some precautions. But yeah, I think there's two sort of particular hurdles I have sort of witnessed, and it's the group that really want to be pregnant, so just can't bear to wait any longer, so you know, and are not going to follow our advice and are going to try straight away. And then the group that just don't believe it would ever happen, so don't see the point. And I think, you know, it's a slightly different conversation with both of them, but it is just trying to promote it and help them realise that it is something that may well happen, and whether they want it or not, it's still not an ideal thing to do initially. In terms of the best methods, so I would always suggest the long-acting methods, and I think going back to Tony's talk and that you know, really heartbreaking story about the lady who had the negative experience with the smear, I think there's a lot of anxiety in the women I've met about having coils and whether people will be willing to fit them, whether it will go well, and I think I think that could be a barrier, or at least a perceived barrier. So my personal recommendation would be the implant, because it's in your arm. There's no sort of, there's no embarrassment, there's no concerns in terms of technically it being more difficult in women with obesity. So I think long-acting methods would always be recommended if people are open to them. And yeah, if there's anxiety around having speculums and having intimate examinations, then the implant is great because it avoids that.
I have got one more question from the audience, but I'm just really concerned about the interest of time about moving on. So I don't know if you'll be around, whether the person can maybe message you in the discussion part of the online platform. Maybe that's a possibility as well.
Yeah,
but thank you very much. That was an excellent talk. And I think great if there's actually more collaboration with BOMS and yourself to actually take this information forward. So thank you.
Thank you very much.
Thanks. I'm going to hand over to Tamara sorry, Tamara, I lost it now. Sorry, who's chairing the next session.
Okay, so I have the great privilege really to introduce a highly esteemed colleague and trailblazer in bariatrics in the UK. She is a consultant dietitian in obesity, and she works presently at the Leeds Teaching Hospital. If you look at her bio, you will see lots of other involvements, but she's led working groups in developing the National Bariatric Surgery Guidelines to improve patient care. And she has a wealth of knowledge and experience in bariatrics. It's with great pleasure I'm going to introduce Mary O'Kane, who really needs little introduction, and she's going to speak on the BOMS endorsed dietary guidelines, what's new in it. Thank you, Mary.
Thank you, Tamara. And my presentation is pre-recorded, so hopefully it'll be launched soon. Thank you for the kind invitation to speak here today about the BOMS guidelines. And it's a real pleasure, as nutrition is such an important part of the care of patients after bariatric surgery. So these are my disclosures. So the BOMS guidelines were published in 2020. And as you can see from here, we had a large working group. Several of us are dietitians. We had a couple of general practitioners, and this was really important because the care of patients is discharged back to primary care, the general practitioners, after 2 years in the UK. And we had a couple of surgeons, and in addition, we had several obesity physicians, of which 2 were also chemical pathologists, and this proved to be very useful for the guidelines. We had a clinical fellow. And then we also had 2 patient representatives, Professor Alex Blakemore and Iris Macmillan. Sadly, Iris died before the guidelines were published, and we dedicated them to her. So the original guidelines back in 2014 were written following my master's dissertation. So much of the research had come from there. And whilst it was fairly robust, it probably was not as comprehensive as what we did for these guidelines. We're looking at the patients and pre and post surgery, and we're also looking at adolescents as well as adults, and also we included pregnancy. We excluded the studies where there might be issues such as celiac disease, but all the patients, all the papers that we reviewed were for the population either going for bariatric surgery or for after surgery. We included the more common bariatric procedures done in the UK at that time, which has also included the gastric band, the sleeve gastrectomy, rheumatoid gastric bypass, and the duodenal switch. There was definitely interest and in the one anastomosis gastric bypass, and also we're obviously aware of the single anastomosis duodenal switch, the SADIS as it's usually known. But unfortunately, in 2018, January 2018, there's very little literature actually reporting nutritional outcomes. We ended up looking at over 600 papers, and we screened the abstracts, And then Harold and Peretti and I looked at the full papers, and we ended up with 139. And I think what's really important for me was actually using a librarian skilled in doing literature searches, because that was a much more comprehensive literature search than I could do, and certainly a lot quicker. Then when we start to look at the methodology, our methodology was robust. We had a huge data extraction form, and we also used quality assessment tools and different ones for each type of study. And that took a huge amount of time to actually collect the data, because we're looking at pre and post surgery, we're looking at different timescales, and we're looking at different nutritional parameters. From there, we're able to assess the quality of the evidence. And as you can see, it ranged from 1++ to 4, where 4 was the expert opinion. And then 1++ was the meta-analyses or RCTs with low risk of bias. And as you can imagine, there weren't many papers that met that criteria. The data was synthesized. And then from there, we made draft recommendations, and then using the quality of the evidence, we're actually able to grade those recommendations. So these were reviewed by the whole group, and it was an iterative process until we're able to reach consensus. So we've graded the recommendations, so that's new. But also what I need to point out is that the grade recommendation is a reflection of the evidence base, but it doesn't reflect necessarily the clinical importance of the recommendation. So when we look at the preoperative screening and what's new, we continue to recommend checking haematinics, calcium, vitamin D, and parathyroid hormone. And we've actually got a stronger evidence base for that. And this is quite interesting. I think it reflects a change in practice, because back in 2014, there were some questions raised as to why we need to do preoperative screening. And for me, it's a given, because if we don't, and we don't correct those nutritional deficiencies, the patient is going in for surgery with a disadvantage. And we still continue to recommend checking PTH levels before surgery, but this is actually to rule out primary hyperparathyroidism. And then a new recommendation is for the malabsorption procedures. We know that these are going to affect fat-soluble vitamins and trace minerals, and so we're suggesting that people should consider checking these before putting the patient forward for malabsorption procedure, and of course correcting them if there's a problem. Then with the post-operative care and follow-up, we have lifted some of these recommendations from the NICE guidelines. They're very, very similar. So we've got the NICE clinical guidelines 189 and also the NICE quality standards 127. And what we decided to do was that if we were looking at clinical guidelines and actually not reviewing the original papers, we'd actually class those as expert opinion. So that's why they are strong recommendations, but we've had to class the evidence base as low, because we're actually taking clinical guidelines. But they are strong recommendations that there should be dietetic input, and that patients should be followed up for a minimum of 2 years, and that also patients should have access to long-term follow-up and preferably a shared care model of management. So what's different about the post-operative monitoring? So one of the big things we ended up discussing was thymine, and I think all of you will be aware of the issues that thymine deficiency can occur, that can cause, but also the fact that thymine deficiency is preventable. So this is why it's really important to consider this. We are very much aware of the American Integrated Health recommendations, and these are excellent guidelines, and they recommended that at least 12 milligrams of thymine a day should be given, and possibly even 50 milligrams of thymine from a B complex in the initial, I think they say for about a year after surgery. But when we looked at the evidence base, from what I could see, it was actually based on low evidence. And they also were aware, though, that when patients go forward for bariatric surgery, there's several risk factors, and that includes that fast weight loss. They're going to have poor nutritional intake, even if they're doing everything that is recommended, and they may have difficulty getting hold of vitamins and minerals and actually taking them. And then, unfortunately, some patients may have problems such as vomiting. So because of that, and we want to make sure that patients are protected, we said consider recommending oral or vitamin B co-strong tablets the first 3 to 4 months. And, you know, it'd be great if we actually got a stronger evidence base to support this in the future. We also felt that that it's really important that clinicians all know about the risks of thymine deficiency. And I think those of us working in the bariatric surgery field do. However, there are many people who work outside the bariatric surgery field who don't. So it's really important that general practitioners, emergency departments all know about the risks and actually treat immediately if there's any concerns. And then also, I think we've got responsibility to make sure that our patients are aware. Quite often they may have issues of vomiting and they don't want to pester the healthcare professional, so they may not bring that to their attention waiting for the next review. And so we need to advise patients that vomiting after bariatric surgery is not normal and that they should seek early advice. Then looking at vitamin D recommendations, and in our initial guidelines, we'd recommended 50 nanomoles per litre of vitamin D, but was aware that many guidelines were actually recommending 75 nanomoles per litre. I'd also read several papers, including a couple of excellent ones by Chaktora, where she looked at RCTs, a systematic review of RCTs, and another one of observational studies. And what she concluded is that when guidelines recommend 75 nanomoles per litre, it's actually based on expert opinion rather than robust evidence. And she was suggesting that aiming for 50 nanomoles per litre after bariatric surgery was sufficient and called for further research. So it's a question of, did we stick with our 50 in our original guidelines? Did we go with 75? And Julian Barth, who's on the working group, is a chemical pathologist, and he explained to me that we'd recently changed our assays in Leeds, and their assay that we're now using in Leeds actually measured vitamin D levels as higher than the previous assay. So we could have a patient in Leeds having their vitamin D levels measured, and then they could go to another part of the country with a different assay and the vitamin D levels would be lower. So in the end, we went for 75, knowing that in some cases it may actually be lower or it may be higher depending on the assay, but also that level is not going to do any harm, and hopefully it means that most people will have sufficient vitamin D levels. So we concluded that aiming for 75 was sufficient, but it's based on a low evidence base. So again, anybody interested in bariatric surgery and nutrition and research, there's further research to be done. And then also advising on how much supplementation to give. And I think in our last guidelines, we recommended 800 international units of vitamin D as a starting point. And we do know that some patients, this actually meets their needs. But equally, there may be many others who actually need increasing amounts. So that's why we've said about a maintenance level of between 2,000 to 4,000 international units of vitamin D after sleeve and the renal gastric bypass. In my experience, a lot more is usually needed after the malabsorptive procedures. But what's really important is actually about monitoring, because I've come across patients whose levels have actually increased significantly on 800 international units of vitamin D. So I think we do need to actually individualise. We need to give supplements, but we also need to monitor and correct accordingly. Then for calcium, this was really interesting because in many of the papers that reviewed, very, very few talk about calcium intake. So it's hard to know what we should be recommending. We know that our RDAs for people who've not had bariatric surgery between the UK and the US are different, the US having higher requirements. And then we looked at the guidelines that made recommendations. Many of those recommendations were actually based on the 2000 mechanic guidelines. So this created a bit of dilemma as to how much to actually recommend. But we also know that when people have calcium from the diet, it's actually better absorbed. We are fairly certain that people, when they have a sleeve or a gastric bypass, that calcium absorption is adversely affected. And certainly it will be the case with malabsorptive procedures. So we put the emphasis on recommending a good dietary intake, and dietitians are able to assess and should be able to make a clinical judgment about the calcium intake. If there's any concerns, obviously they can recommend a calcium supplement. And also acknowledging that PTH levels are sometimes, raised PTH levels can sometimes be a sign of insufficient calcium, especially in the presence of good vitamin D levels. There's many calcium checkers on the BDA. Food facts, we have a range of foods and how much calcium they can give. And I think if anyone's got concern, is actually maybe recommend a calcium supplement, but certainly if PTH is raised, is actually look at calcium intake, and also if vitamin D is normal, focus on the calcium rather than giving extra vitamin D. Also, for the last few years, we've had quite a few discussions in the UK as to whether or not we should be looking at a different method of vitamin B12 supplementation. And this is a perfect opportunity to review that evidence base. So we found that the very limited evidence for high doses of oral B12 in patients undergoing bariatric surgery. There have been a couple of studies, and a fairly recent one, which was in patients with a rheumatoid gastric bypass, and it was a short-term follow-up. Could not find any evidence in people who've had bariatric surgery where they looked at intranasal or sublingual vitamin B12. But there is excellent evidence to support intramuscular injections. We know that adherence to oral can be more difficult to determine, and that was certainly reported in some studies. But also a big factor is that vitamin B12 deficiency is preventable. But if it's not diagnosed and it's not treated, it can lead to irreversible neuropathy and subacute degeneration of the spinal cord. So we felt the evidence base was robust enough to still recommend intramuscular injections of vitamin B12. Now, a big issue was about the malabsorption procedures. And I think what I want to highlight here is many of them have been around for a long time. There are several papers actually reporting on nutritional outcomes after duodenal switch, but actually much less so on the one anastomosis, gastric bypass, and the SADIS. A couple of papers came out after we'd done our initial literature review, and in discussion we decided to count the one anastomosis gastric bypass with a BP limb of 150 centimetres like the rheumatoid gastric bypass. However, if it's greater, and for patients who've had a SADIS, we were counting that as being very similar to the duodenal switch. So for malabsorption procedures, we know that fat-soluble vitamin deficiency is common. And it might not be measured in all papers, but where it is measured in studies, there is quite a high prevalence. We don't know how much vitamin A, though, to actually start with. So we've made a suggestion about how much vitamin A, E, and K to actually start with. And I think what you should note that these are actually good practice points, and it is actually a starting point. Then we look at the monitoring, though, because of the high risk of fat-soluble vitamin deficiencies after bariatric surgery, we're able to make strong recommendations about the monitoring of these vitamins. And I want to highlight this because, unfortunately, many bariatric surgery centres cannot measure fat-soluble vitamins, and this is going to be a real challenge if there's going to be an increase uptake of malabsorption procedures. Also, what's new is that vitamin K, in the past, people have looked at clotting factors as a way of actually monitoring vitamin K. And the more recent evidence says that this is not acceptable, that we do need to be measuring vitamin K levels. So in those centres that do malabsorption procedures, they do need to make sure that they have got access to appropriate monitoring. So what's new? The recommendations for pre-operative and post-operative nutritional assessment and monitoring are actually very similar for both guidelines, the ones we did in 2020 and the more recent in 2014 and the more recent in 2020. But what I would say is we've actually got a stronger supporting evidence base, which has been quality assessed. The other new one is about recommending additional thymine in the early post-operative stages. It's not a strong recommendation, it's about consideration, but it's certainly probably an area that we need to be looking at more closely. We did go with aiming for 75 nanomoles per litre of vitamin D, which it is based on a weak evidence base. And I think we've got stronger justification for continuing with intramuscular injections of vitamin B12. Now, with the malabsorption procedures, we have said about the importance of considering checking vitamins A, zinc, copper and selenium preoperatively. But also it's very strong recommendations about routinely checking vitamins A, E and K. And then we've made a recommendation about supplementation, but that's purely a starting point, and it's likely that patients will need higher levels. We also recommended that patients who have malabsorption procedures remain under specialist centres. And I think what I haven't said is that in the papers we have looked at nutritional deficiencies and correcting, but quite a lot of those recommendations were similar to the 2014 guidelines. And also want to say that we really want to emphasise the importance of doing longer follow-up with patients and making sure patients have access to lifelong nutritional monitoring and aftercare. So a huge thank you to the working group. They did work really hard. I think it was a much bigger task than I'd originally thought, especially because of the data extraction and assessing quality of bias. But I think we've got more robust guidelines. And finally, thank you. And have you got any questions?
Okay. Thank you very much, Mary, for that talk. I must say I've been working in bariatrics for a long time, and it's very refreshing to know that we've got guidelines and recommendations for vitamins and minerals, because for many years we've sort of been asking each other what to do, and so having guidelines is really refreshing for us. So we'll take any questions. I'm not seeing any questions coming up.
I think for me, I think the guidelines are just a starting point. And for me, it always brings up that dilemma. Is it the vitamin and mineral supplements that are most important? Is it the monitoring? And I don't think we can actually have one without the other. I think both are equally important. And also, I think when we do the blood tests, it's actually checking those results and actually adapting the vitamin and mineral supplements accordingly. I think for me, the big question is the fact that we do have a postcode lottery with vitamin and mineral supplements, and also sometimes access to monitoring, and that is an issue.
Yes. Okay, so we've got some, okay, these guidelines are life-saving, some comments. Do you think we can have simpler to understand for patients, as some patients carry these guidelines? So maybe simpler information for them?
Yeah, I think one of the areas that we wanted to do after the guidelines are published, and being quite slow at doing this, is actually doing a form of the guidelines which is actually for patients. So very easy to follow, so to be able to go back to the GP with the information, and also discuss with Helen Peretti about doing a form that's actually suitable for general practitioners as well. So it is further work that we need to do, but I think that's really, really important.
Okay, another question. Is there any further guidance for usage of vitamin B12 oral sprays or drops to treat deficiencies?
It was quite interesting because we made the decision that when we were looking at the evidence, we were actually only going to look at those studies in the bariatric surgery population. And there isn't the evidence for the oral sprays and under the tongue. The evidence for oral B12 is still very, very sparse and actually small groups and maybe not very long follow-up. And what we were doing was looking at the benefits and the risks. And what we're concerned about is the risk of untreated and undetected vitamin B12 deficiency and severe consequences that that has. So that's why we've still gone through for the regular B12 injections.
Okay. Lots of questions are coming in. So another one is, are there any specific fat-soluble supplements that you recommend for more malabsorptive surgeries?
Yeah, it's difficult because in theory, you're not supposed to recommend any sort of brand names, but there is a fat-soluble vitamin that's available that's water soluble, and we think it is better absorbed. I think the difficulty we have in the UK as opposed to in other countries, although that vitamin has been is available and licensed for cystic fibrosis, in the UK, it's not licensed for bariatric surgery, so it's very difficult. And what we did in Leeds, this is where I think somebody mentioned earlier about having a really good rapport with the commissioners, is we actually went to our commissioners, but we also went through drugs and therapeutics to actually get that fat-soluble vitamin available on prescription for people in Leeds and Leeds area to actually have on prescription. So I think we need to do a lot more work. We need to do a lot more work with the LIBSS in actually getting more medications approved, because certainly in the UK, the expectation is we would like these vitamin and mineral supplements to be available on prescription to actually help with adherence as well.
Yes, lots of questions are coming in. Mary, I'm not sure whether you want to continue answering questions or we can leave them for later.
I'm happy to leave things for later because we've got the discussion coming up, and also yes. I'm happy to be contacted as well. So it's a chat forum, and I think a lot of people do know my email address, so I'm happy to make it available as well. So and also what it means then, if you ask.
Okay, I think there may be some technical difficulties there. Oh.
Yeah, it is frozen.
It seems like Mary's frozen, yes. So Mary was to chair the next session. I'm not, okay, she's back on. Okay, great.
Am I losing connection again?
Yeah, you did for a couple of seconds.
Sorry about it, because it went down completely, so I'm just hoping it stays on. So the next session is going to be a brilliant one because it's a multidisciplinary team, and we've got fantastic teams. So we've got you, Tamara, as the bariatric specialist nurse. We have Sophie Wilson, who is a bariatric specialist dietitian, Dr. Melanie Randall and Dr. Max Major, who are psychologists, and Dr. Manisha Sharma as well. So the reason why we're doing it is that we're aware that the number of patients having malabsorptive procedures is increasing. And the one we're going to focus on today is the one anastomosis gastric bypass, which is also known as single anastomosis gastric bypass or mini gastric bypass. But we also have surgeries like the SADIS. And we know that malabsorptive procedures, it's going to impact on absorption of fat, protein, fat-soluble vitamins and trace minerals. And this raises issues for the team because we've got to be even more careful about that pre-assessment and then actually about that post-operative support. So tomorrow is going to kick off with a case study, which will just give an overview, but we'll then try and widen it out to the wider picture and malabsorptive procedures in general.
Okay. So this case study is just a reference point for our panel discussion. I'll share my screen. Okay. So of course we're using a pseudonym. So this case study is on a 27-year-old female who came in for bariatric assessment in 2018. Then she had a BMI of 36.4, weight of 105.4. She went through the pathway, was discussed an MDT and cleared for surgery on the 8th August of 2019. And then had a single anastomosis gastric bypass in January of 2020. She was then 96.2 kilos. She has a past medical history of type 2 diabetes, high blood pressure, reflux, fibromyalgia, and that's joint pains, so lower back pains, hip and knee pains. And at the assessment, she was sent for a sleep study. She also had a significant mental health history of borderline personality disorder, anxiety, depression, suicidal thoughts, and she had past self-harm. And she also had binge eating in the past. Due to her fibromyalgia, her physical activity levels were quite low at the time of assessment, although she said previously she was walking a lot and she loved hiking, so she did a lot of walking. Her dietary history at the time, she was vegan, she had done a lot of diets in the past, yo-yo dieting, so she would be up and down, she would binge eat, she would lose weight and, you know, regain again. Her current dietary history, when she was assessed, she was skipping meals, she was still having binges, and she was seen by the community dietitian who felt that she was unsuitable for surgery at the time. So social history, she lived alone, she was unemployed, and a lot of it was due to her fibromyalgia. She was just unable to sort of commit to any job because she was always unwell. She said she had supportive friends and she was smoking cigarettes and marijuana occasionally. So just an update of what is happening with her now. So this is a year down the line, or just over almost 2 years, because she had surgery in January of 2020. She's still vegan, so which makes it hard for her to meet her protein requirements. She has not been attending the dietitian's appointments, although some of them have been online and telephone. Her last review, she was not taking her advised vitamins and minerals. She was still smoking. She had achieved a lot of weight loss, which was a concern because it's over 100% of her excess body weight. Her hair was thinning, and she was not meeting her protein, calcium, or fluid requirements. And she had not arranged any blood tests from her GP. Yes, so that's the case. I'll stop sharing the screen now. Okay, Mary. Yes. Sorry, you're on mute.
Myself, sorry. So that's obviously a very complex case, and we've all got examples, I'm sure, of similar situations as well. So just starting, going back in time, I know that the patient obviously went ahead and had surgery, but what's the views from each of the team about what issues were raised or should have been raised at that time? I know it's always easy with hindsight, but what kind of things would you think were important to raise as members of the team? I don't know, Sophie, if you want to start as a dietitian.
So the dietetic team did raise concerns about this patient just based on the fact that she's a vegan. Obviously, you can eat a really high protein diet as a vegan, but it is much harder. You have to put a lot more work into it. And we felt that with that complex kind of mental health history, I really struggled to meet her protein requirements on a vegan. So whilst she was surgery dietetic, we really did advocate for her to undergo a sleeve. And that was raised a couple of times, I believe. So it was raised at the MDT, and it was also raised in an email directly with the surgeon also. Yeah.
And obviously you touched on the mental health side. So Max and Mel, have you got, what were your views?
I saw this lady a couple of times before surgery and raised similar concerns. She didn't have a lot of sort of support or ability to really engage and stand back from a lot of those difficulties to engage with the process. So we raised concerns alongside the dietitians at the MDT. And I think in the end, it was decided that there was surgical need that trumped those concerns. So that's kind of where we landed.
Yeah. And Manisha, with you as an obesity physician, what would your concerns be? Would you be supportive of this patient going forward for surgery at that time, or would it be that further interventions were needed?
See, so I have more experience with the, sorry, am I audible? Am I audible, Mary?
Yes, you are, yes.
So working at Homerton and having the privilege of seeing all the duodenal switch patients, you know, the malabsorption that I have seen over last 8 years. And then I have started to see the patients with the single anastomosis gastric bypass. When these patients, when we were going through the theory and, you know, when this surgery was being promoted, the feeling was it is a less malabsorptive surgery to an extent that even it was said vitamin and minerals, oral supplements, they just need to be box standard. But what I'm seeing from my clinical practice, these patients, some of them can have malabsorption even worse than duodenal switch. And some of them are really difficult to manage with incessant diarrhea 12 to 14 times a day, and high doses of creon not helping bile salt malabsorption. So I see this surgery as probably with the mechanism different from duodenal switch, some of these patients, and especially because these patients can also have other comorbidities which complicate the overall picture. These patients are very high risk patients. So if this patient with a vegan history and mental health issues, I would be very skeptical. And if I'm there in the panel, in the MDT team, I would highlight my concerns against the surgery.
Yeah. So before I move on to the MDT decision, I forgot to introduce Jennifer, who's a physio. So it's really nice to have Jennifer. Jennifer, is there anything that you'd want to add to the pre-op assessment from a physio point of view, activity-wise?
I think from as being part of a member of the AHP team, we're able to kind of really collaborate and discuss what we see. And I think when I first saw this patient, I was just really concerned about her general mental health. Even before we even got to talk about any kind of, you know, ways to increase activity levels or anything like that, I just felt that engagement was really poor. I thought her history tenor was really poor, and it just seems like, she just seemed to be in the right place to be in the service at this time. So I think I remember bringing it back to the AHP team to really just discuss her and her case, and then arts for psychology to really interject at that point.
So obviously we've all had a situation where we've got a complex case who's presented to the MDT, and we can all have very different opinions and different views. It sounds like in this case that the surgeon's voice may have been the strongest, but I don't know if I'm picking that up right. So how as an MDT, and how should we actually look at the MDT working, and how do we actually manage those different views and opinions, and who should have the final say about what procedure they have? You know, any views from the team on that, or even if surgery is suitable at all at that time?
Well, I think definitely it needs to be collaborative. That's why we have an MDT. So all of us can bring from our specialities, bring out what we've assessed about this patient, or patients that we discuss. But I think it's very important also for patients themselves to understand the procedure that they are having. And I get a sense that sometimes patients are not given the full picture, especially with these very malabsorptive procedures. So they may be told one thing, but not the extent of what can, what can really go, if something goes wrong, or if they start getting malnutrition, how do they handle those things? And I think it is collaborative, but we have to make sure that the patient understands exactly what they are getting themselves into.
Yeah. So
go
on. Yeah.
I completely agree with you, Mary and Tamara, because here it is not only the information that is given to the patient, is also the ability of the patient to comprehend complex scientific information. I'll be in my subsequent talk, I'll be touching all these things. So if a patient has, I think a big alert sign should be pre-operative nutritional deficiencies or metabolic disorders. And if these things are there, we know first the patient will not be able to understand, will not have the strength or stamina or the mental capacity, composure to understand the complexities, because they just want to lose weight and have the benefits.
Yes.
So it's very important that as a collaborative team and empowering the patient, like a few speakers, they were talking about empowering the patient. But empowering the patient also depends on the patient's mental, physical, and emotional health. That has to be robust before we can have a proper consenting from a patient. So it's a very, I think we all probably need more time is needed to be spent on understanding that has patient understood everything what they are signing for? Do they have the mental capacity? And then a collaborative MDT decision should be signed off before such life-changing and altering procedures, which stay with the patient lifelong.
Yeah. And I have a question in from the audience. It's about the pre-op assessment and that. Did the patient have any input, help with binge eating disorder before going forward for discussion?
Sorry, what did you say?
Yeah,
Sorry,
it's a question for, it's probably for Mel and Max, is did the patient have any help with managing binge eating disorder before the case was discussed?
Sorry, just before I answer that, our internet is really poor, so we're struggling to kind of keep up. But I can see some of the questions coming through in the chat. She had engaged with almost every service, mental health service available to her in her local area, and had been seen by them, including treatment for binge eating. It was more, when I saw her, it seemed more related to her pain management, sort of on the on the so-called good days. On the bad days, she wouldn't eat anything at all because she felt she couldn't get out of bed, and then on the good days, she would sort of make up for that by eating a lot. She didn't really seem to engage with any of the mental health services that she was open to. So I guess the answer is she had input, but it didn't help her resolve any of the treatment, any of the difficulties she was having, which was all raised at the MDT.
Yeah. Mel?
Oh yeah, and Mary, I guess I just wanted to add, because I think the issue for me here is I'm sitting there just, let alone seeing the slide, let alone hearing, and I'm sure I'm not the only person that's just like, how on earth is this person being operated on? And I think sort of part of why this case was chosen is because this also boils down to, how do we make collaborative MDT decisions? And again, this issue of surgical need overrode sort of, I guess, concerns that were raised unanimously across the AHP team. And I suppose it's how do different centres manage that, where there's quite considerable differences of opinion. And we've done that historically through making sure that AHP's concerns are documented. But yeah, I guess this is a sort of ongoing issue around consent and decision making, and who has the power to ultimately make the final decision.
Yeah, and because at the end of the day, we've got a patient at the end of this who may not do very well after surgery and have lots of complications, as this patient seems to have. Some of the questions coming in are also about the diet, because obviously we'd be looking at a higher protein diet. And Sophie, you've already touched on the chart, the fact that the patient is vegan, so it's going to be a higher volume of food that needs to be eaten. So what challenges for you as a dietitian were placed after surgery? And just comparing maybe the time input that you'd give maybe to the patient who's had a sleeve or a gastric bypass is fairly straightforward. But if we've got a patient with complex needs, having a malabsorptive procedure, what's the difference in the management afterwards?
That's 60 to 80 gram target.
Sorry, the volume's not very good, Sophie. Or it might be my internet, I don't know, it might be me, so I don't know. Is anybody having problems with the volume, or is it just me?
No, I can't hear Sophie.
Yeah.
Is that any better?
Yeah, I think you need to speak up loud because it's not very loud. So yeah.
Yeah, I can hear you, Mary, very well. So
can you hear me though?
yes,
it's very faint. Yeah.
Basically, what we found anecdotally from the single anastomosis gastric bypass patients is that they do have much higher protein requirements. In extreme cases, we've had patients having maybe an intake of 150 grams a day and still rapidly losing weight and rapidly losing that lean muscle mass, which obviously we want to avoid. So I think at the time that this patient had surgery, that wasn't something that we were kind of recognizing enough as a service. And since then, we have changed our practices. We do tell patients that their protein targets are going to be much, much higher. But yeah, I mean, it's when you're dealing with these more malabsorptive procedures, it's not just a case of 20 grams each meal 3 times a day, which is relatively manageable. They need kind of protein-based drink, additional. Our patients are really long-term intensive oral nutritional supplements, which can be difficult for them to manage in terms of like palatability, the taste, accessing those things from the GP. So it is a very different way of managing these.
Yeah. So thanks, Sophie. The volume is going up and down. So for what I gathered that there was the requirements of the patients, the protein requirements much higher. It's actually difficult to meet, and there's actually patients undergoing malabsorptive procedures are likely to need more time input and support afterwards as well. And then I don't know, Misha, because I think your volume is okay. So is one of the questions that's come in is what's the best way of actually informing the patient about the risks of surgery without overwhelming them, so they can actually make an informed decision and consent?
I think, Mary, are you asking me?
Yes, I think you, because I think your volume is definitely okay.
Thank you. In response to Vanessa's question, I think there is no shortcut in this, because what we have seen that if we do not spend enough time, probably much longer than what we are currently spending in informing these patients, because this seems to be almost like duodenal switch or even worse in some patients. So these patients, I sometimes tell these patients that you have a new body, but your brain is there, but your body has changed. So you have to actually learn like a new baby learns how the bowel works and how your eating habits and everything. So we have to explain the risk in detail. We have to explain the way of life in detail. We have to explain the dietetics and all the requirements in detail, so that these patients can benefit from the surgery and have the quality of life they are anticipating. Otherwise, it's a downhill process. And in answer to one of the questions, how do we see which are the right patients? Actually, like all of us in our practice, we might have seen some patients who are constantly ringing the secretaries to ask about their results, who are constantly trying to chase you, finding your email. These are those patients who would be suitable for such malabsorptive surgery, because they'll be on top of their vitamin minerals, they will be on top of their blood tests and all the requirements. So Mary, you asked who should make the final decision. I think it's a very tricky question, because sometimes in MDT, the decision is such that when the surgeons will go and do the laparoscopy, they will decide on the table what is best suited, considering what is the internal picture. But I think as a MDT, if we see very high risk red alert patients, maybe at least we can say whatever surgery, but this surgery will not be suitable. That's a suggestion, I don't know. So you can say as a team, if we highlight as different members saying sleeve gastrectomy and gastric bypass is okay, but mini gastric bypass is not suitable for this patient. So at least when the discussion is happening with the patient, he or she knows that this will not happen. And the surgeon also know that this was discussed thoroughly and other MDT members had concerns. Just a suggestion, I don't know how difficult or easy it will be.
Yeah. I mean, I agree. I think it's very important as a team to come up with a collective view. And so from patients like this one, you know, and I think we've all got examples in our MDTs where after to think that possibly wasn't the best decision. What lessons can we as a team learn to actually make stronger decisions and better decisions for patients? Because I think, especially for the malabsorptive procedures, there's all the psychological issues that all patients have, but we're also looking at finance, family support, and all the issues that help people. So it's how do we make better that shared decision making and make it stronger so that we can avoid issues such as this patient going forward for that type of surgery at that time.
I think from a nurse's point of view, we act as an advocate as the other AHPs for patients, and you develop a relationship with them. So for me, in the MDT, I need to make sure that my voice is strong enough to, you know, advocate for the patient. And as you've said, Mary, not just the physical, but we're looking at the socioeconomic aspects, the psychosocial. So bringing out everything, laying the cards on the table, and then collectively making that decision. But really studying our patients and knowing exactly, you know, holistically what this patient may or may not be able to cope with.
And I think you're very fortunate at Homerton because you do have a very good setup. You've got a very strong MDT, and also you've got Manisha, who's an expert on managing nutritional complications. And I think my concern is as well, that I mentioned in the talk, is that sometimes we don't have that easy access to the right supplements for those patients after surgery. So it might mean they're buying lots of things which they may or may not be able to afford. And then also if centres are doing the malabsorptive procedures but actually don't have the ability to do some of the nutritional monitoring afterwards, that is a real concern as well. So I think I'd like to keep this discussion going. I know that we're short of time now, but it'd be nice to keep this discussion going and actually look at it, certainly in the UK from a BOMS point of view, about how we actually do this better. And I think we can use our society with our integrated health reps as well to actually come up maybe with some work around the MDT as well. So I think just in the interest in time, and just because I know that some of the volume for some of the speakers is actually not that great, I think if it's okay with everyone, I'd like to close this session and introduce the next chair to take forward the next and final session of this morning for us. But thank you very much. It's really interesting. Yeah.
Thank you very much. Thank you, everyone.
Right, no, thank you. Thanks.
Thank you very much, Mary. So the next talk, I mean, it gives me pleasure to introduce the speaker for the next talk, Dr. Manisha Sharma. She is a brilliant colleague of mine. Dr. Sharma is a consultant chemical pathologist, bariatric and lipid specialist at BARTS and Homerton University Hospitals. She has contributed to the BOMS guidelines, and Manisha runs specialist chemical pathology clinics for high-risk bariatric surgery patients. So it gives me pleasure to invite Manisha for her talk. The screen is yours, Manisha.
Thank you so much, Sarah. Thanks a lot for very, very kind, generous words. So I'll be talking about preoperative tricky nutritional and metabolic derangements. requiring prompt attention, and we'll be just straightforward going to case studies and some problem solving. Right. So as you know, we are following up from the discussion that has been happening after each talk. Preoperative optimization of a patient depends on effective engagement of the patient with the bariatric MDT and ability to comprehend complex scientific information and to apply it in their life and future decision-making with regards to life with bariatric surgery. And then the patient is also asked to work towards achieving 5 to 10% weight loss prior to the surgery, utilizing the specialist advice of all MDT members, predominantly dietitians, physiotherapists, and psychologists. When there is a failure to do so by the patient, there is inadequate weight loss. And this is usually considered as a red flag that patient, if he or she has not been able to lose 5 to 10% weight prior to the surgery, how will he adhere to the lifelong lifestyle and dietary modifications required in the post-operative period? Now, delay in surgery is not only a delay in surgery playing on the patient's mind, but it's also exposing the patient to all metabolic and surgical complications associated with obesity. Needless to say, obesity is associated with hypertension, diabetes, sleep apnea, thereby increasing cardiovascular risk of heart attack, stroke, cancers, and even death. So what are the main hindering factors affecting effective patient management, motivation, and achievement of pre-op targets? And this is just few of them, the factors which I am saying: memory, energy levels. Most of us will see patients who have got very low energy levels, and their main dedication is to just get the surgery, lose weight, and then they will do everything that they want to, like exercise and everything. So they're looking for a quick fix, and we can't blame them because they have been dealing with that level of obesity for decades. Again, another hindering factor is lack of reasonable exercising capacity with breathlessness. And do they have reasonable health to achieve those goals? Because a lot of these patients can have constant headaches, palpitations, bone pains, dizziness, low mood, brain fog. We know all these patients are not healthy, and it's not only the weight which is a problem, they have got other health issues as well, which prevent them from achieving all these pre-op targets. So common preoperative nutritional and metabolic challenges contributing to all the symptoms, to most of the symptoms, are usually iron deficiency anemia, vitamin B12 deficiency, folic acid, vitamin D deficiency with secondary hyperparathyroidism, or if a patient is has known thyroid condition like underactive thyroid or hyperthyroidism, these patients can have a lot of symptoms. And we know obese patients, they have more weight, but they are malnourished, not because of lack of nutrition, but because of poor nutrition. So any patient with untreated single or multiple coexisting treatable nutritional or metabolic issues preoperatively, in my experience with working with obese patients for more than 20 years and working with bariatric surgery patients for around 8-9 years, they will not achieve maximum pre or post-op weight loss or quality of life targets. So this is a case where a 66-year-old man with hypertension, type 2 diabetes mellitus, sleep apnea, atrial fibrillation, hypercholesterolemia, gastroesophageal reflux disease, hypothyroidism, psoriasis, BMI of 42. Non-smoker, non-alcoholic. Medications are amlodipine, metformin, amiodarone, an antiarrhythmic drug, thyroxine for hypothyroidism, rosuvastatin for cholesterol, insulin, and lansoprazole for reflux. I have put the star against some medications here because these medications have got impact on a patient's metabolism and some nutritional deficiencies. So this patient, after the initial assessment, was treated for folic acid and vitamin D deficiency. But the patient remained unable to lose 5% weight loss despite rigorous support and motivation by the AHP team, because patients had complaints of lack of energy, palpitations, breathlessness, bone pain, but was always tearful and desperate to get the surgery. So when the initial tests were done, the patient had low folic acid and vitamin D, which were being treated, had a high PTH, which suggests, so vitamin D low and high PTH suggests that the patient is secreting more PTH to maintain the calcium level, and that's why this is secondary hyperparathyroidism. So when a patient has low vitamin D, which is not sufficient to absorb calcium from the food, PTH is released from the parathyroid gland, which releases calcium from the bone, but then it leads to bone pains. And again, vitamin D is low. It has got multiple actions, not only on your immune system, your mood, bone pain, everything. And this patient had a normal free T4 on thyroid function and a TSH, which looked less. So this was something which prompted second line of treatment second line of testing, which is we offer active B12 holotranscobalamin at Homerton and MMA testing for functional deficiency of vitamin B12. So, and free T3 was added to this thyroid function test where free T3 was seen to be high. So this patient in the first line of test, if you see, free T4 was normal, but TSH was low, but this should have suspected additional testing of free T3 because this patient is hyperthyroid in thyroid status. And although B12 level looks normal as per the range, but this is a misguiding test, as we all know. We have read a lot and we know it. Active B12, patients with normal B12 can have severe vitamin B12 deficiency, and that's why a patient with neurological complications, such as some sign and symptoms suggestive of vitamin B12 deficiency, should be investigated for these second line tests, and these showed very severe deficiency. And this patient had high free T3, which is the active form of thyroxine. So the biochemical diagnosis and clinical correlation, this patient had high free T3, normal free T4 disguising. So the clinical correlation was this patient had over replacement of thyroxine compounding atrial fibrillation. Thyroxine is a hormone which increases your heart rate. This patient already had atrial fibrillation. So being in an overthyroid state because of over replacement of thyroxine, the atrial fibrillation was also getting worsened. Second thing was folic acid deficiency. This patient had psoriasis. Any exfoliative skin condition can cause folic acid deficiency, because when you have long, big lesions of psoriasis and there is increased cell turnover, it uses up body reserves, especially folic acid. Same like a fetus growing in a pregnant mother. Why the mother needs folic acid? Because anything that is growing in the body or increased turnover over the skin, as in psoriasis, will take away folic acid. Or even a patient who has a tumor, their folic acid levels drop. So it's for growth. So this patient had a reason even prior to surgery for folic acid deficiency. Vitamin D deficiency explained lack of energy, low moods, bone pains, and inability to engage with the MDT team advice, especially physiotherapists, because this patient was not able to engage in the physical activity required to do to achieve the weight loss. Now, functional deficiency of vitamin B12 despite normal B12 level, and which was evidence on the second line testing, which fortunately we have at Homerton, and we make the most of it. So this patient had neurological features which we could understand were because of severe B12 deficiency, like memory, tearful state, palpitations, and palpitations due to B12 were compounding the atrial fibrillation. So you can see atrial fibrillation was the primary condition, but it was also compounded by over replacement of thyroid, folic acid, and B12. So what is going on with this patient? This is a known case of atrial fibrillation with potentially amiodarone-induced hypothyroidism. It's important to know the consequences of certain drugs in common practice, and that's why sometimes getting help from the pharmacist will also help. So this patient has been on this drug which probably induced hypothyroidism, and the patient was getting too much thyroxine, probably not monitored during the pandemic, because we know for last 2 years it has been extremely difficult for the patients to go to the GP for the blood test, and the thyroxine was more for the requirement. So although free T4 was normal, TSH was suppressed, and free T3 was done. Vitamin B12 deficiency, if some units are not doing, so what I'm trying to say is if some units are not doing active B12 or MMA at low normal range of vitamin B12, they might miss B12 deficiency and treat a patient with folic acid deficiency, like in this patient where psoriasis is giving too severe folic acid deficiency. Such patients are at high risk. So any patient who has undiagnosed vitamin B12 deficiency, if given high doses of folic acid for prolonged period, can have severe neurological complications, including subacute combined degeneration of spinal cord. I have said this in previous talks. I have seen 3 patients in my life till now who had this complication with permanent disability and neurological sequelae. So this is, I hammer about this all the time. Folic acid, again, yes, I mentioned this point. So how did we do pre-op optimization and management? So GP was alerted to reduce thyroxine dose to achieve TSH within the normal range, because we know thyroxine can worsen atrial fibrillation. Vitamin B12 deficiency was treated with 6 serial 1 milligram injections over 6 weeks, and after which folic acid was supplemented. And GP was asked to intensify treatment of psoriasis so that the folic acid requirement is reduced and we can reduce chances of folic acid deficiency after the surgery. Repeat TFT showed normal TSH, palpitations were resolved, and atrial fibrillation also settled. Amiodarone dose could be reduced from 200 to 150 or 100. So this patient had improved quality of life, and the patient could institute robust lifestyle and dietary modifications, achieved weight loss, required weight loss over the next few months. MDT was more reassured to consider patient for surgery, and because the patient had gastroesophageal reflux disease, patient was advised for gastric bypass surgery, especially considering sleeve gastrectomy can change the metabolism of thyroxine and patients can suddenly become hyperthyroid. And that's why in Homerton we have a policy. We check thyroid function test after 30 days. My colleague Tamara will be able to confirm after 30 days after the surgery to check if we need to reduce the thyroxine days. And special emphasis to monitor thyroid function test, including free T3 if TSH was suppressed. So lesson learned from this case is palpitation is not always cardiac in origin. Breathlessness is not always respiratory in origin. Vitamin and mineral disease can affect each and every cell. And again, like this is important. We give all the information to the patient, but does the patient have the ability to understand this information and apply in their life? That's why I feel the first step should be identify any deficiencies, treat them, and then bombard them with all the information, because they will be in a fertile way, they will be able to use it. A patient with optimized pre-operative nutritional and metabolic status is able to make the most of specialist MDT and AHP advice, because their patient is able to understand, grasp, imbibe, and make the most of it. And it leads to low readmission rates post-op and better clinical outcomes. Achieving pre-op goals, including 5 to 10% weight loss, which is a win-win situation for both surgeons and the team and the patient. It allows patient to have realistic weight loss expectations post-operatively, because the patient is able to comprehend the information. They know the complications, they know the limitations, they have a good memory. This increases patient and family satisfaction. And last but not the least, a fully engaged patient during the entire pathway, thereby it ensures a good surgeon, physician, AHP team, all clinicians in the pathway, and a good patient relationship, less complaints and less medical legal implications. Second case. Mary, how much time have I got? I always overrun my sessions. Sorry.
Looking at the timer, it says 16 minutes. It's at the moment it's 5 to 1, so we are running behind. It's not necessarily your talk, but we are running behind. But
so I have got 10 minutes?
I think so. If that's okay with the rest of the panel, yeah.
Yes, Manisha, you've got 10 minutes. Yes.
Okay, thank you so much, Sarah. Thank you. So second case is 45-year-old obese male with a BMI of 36, hypertensive with known history of kidney stones and sarcoidosis in spontaneous resolution, had preoperative bariatric assessment, and severe vitamin D deficiency was treated. The patient developed new complaints of severe palpitations, very dry mouth, and mental fogginess. When we did the blood test, the corrected calcium, as you can see, is very high. Phosphate is very high, and PTH looks low, which is an appropriate response to high calcium. So in human body, when calcium goes up, it suppresses PTH, which is happening here. So that's a normal compensatory response. Two things to remember: that if a patient has got very high vitamin D, it can increase both calcium and phosphate. We have to remember that there is, how do you differentiate with hypervitaminosis D or hyperparathyroidism there? Because the PTH gland is secreting more PTH, calcium goes up. In hypervitaminosis D, where somebody has taken too much vitamin D, the patient has got more of calcium and more of phosphate. Whereas in parathyroidism, it's opposite. Calcium goes up, phosphate goes down. This patient had a creatinine level which was within normal range, but in comparison to the previous level, this patient had doubled his creatinine level. So because this patient had a past history of sarcoidosis, which was dormant, these two tests were done. And the ACE, angiotensin converting enzyme, which is the marker for sarcoidosis, this level was it was high normal, but 125 hydroxyvitamin D is 208, which is almost double of the normal reference range. And this suggested that this patient had more form or more of the active metabolite of vitamin D, which was increasing the calcium and phosphate level. So if you see in this assay, vitamin D, the lab gave a normal result within the range, but 125 hydroxyvitamin D was much higher, explaining the high calcium and phosphate. Now, there were other contributory factors in this patient for thiazide for hypercalcemia, which was this patient was on diuretic for hypertension. And because this patient had kidney stones, he was put on a low oxalate and a high calcium diet. And that's why the calcium was high. There were many contributory factors for high calcium in this patient. So what happened, we found that this patient had active sarcoidosis, which was not present. So this patient was in remission for many years, but when he came for the bariatric assessment, it seems he had active sarcoidosis. X-ray showed paratracheal lymph nodes, which are classical of sarcoidosis. And so what happened in sarcoidosis, there are granuloma formation in the lung. Sarcoidosis can involve many organs, but it involves the lung in many patients, in which there are small granulomas which look like tuberculosis, but they are a different form of granuloma. And there is a chemical composition of those granuloma where the epithelioid cells, they use up the vitamin D and convert to the active form of vitamin D. That's why this patient who was given vitamin D as a pre-operative optimization for the bariatric surgery landed up in having excess of vitamin D, absorbing too much calcium and phosphate from the dairy products, which he was having as a high calcium diet for kidney stone prevention. And that led to hypercalcemia, injury to the kidney tubules, and acute kidney injury, thereby increasing the creatinine level to double. So creatinine level, when you see creatinine level or a potential AKI, it's not just doubling of a creatinine level. You have to see the doubling rather than the absolute value. So what we did, absolute says we immediately stopped vitamin D, thiazide diuretic, calcium-rich diet, and aggressive hydration as management of AKI and hypercalcemia. And the patient resolved, the hypercalcemia resolved, but this patient was deferred from the bariatric surgery for the time being. And as far as I know, is still awaiting the surgery because the sarcoidosis is being catered to. Last case, 57-year-old man came for bariatric assessment with hypertension, diabetes, vitamin D deficiency, past history of excess alcohol intake, and the patient was on following medications: metformin, atorvastatin, fenofibrate, vitamin D. So this patient had a not so low hemoglobin, ferritin was high, could be because of any chronic inflammatory condition. And B12 looks normal. I always suspect low vitamin B12 levels. If a level of B12 is more than 500, I feel okay that maybe the active B12 and MMA will be probably normal. But anything that is sitting below 500 in a reference range of 200 to 1000, we prefer to do active B12 and MMA. Vitamin D was very low, PTH was very high. So this is a classical response of secondary hyperparathyroidism. ALP, the alkaline phosphatase, was 104, which is high. Normal is less than, sorry, I forgot to put the reference range, less than alkaline phosphatase. 102 is our normal reference range, and this was slightly elevated. And GGT was 48. Again, gamma GT was slightly elevated, and triglycerides were high. HbA1c showing poor glycemic control, LDL cholesterol high. So we did second line of testing, which is alkaline phosphatase isoenzymes. Now, normally alkaline phosphatase is considered a liver function test, but alkaline phosphatase can have origin from mainly liver, second bone, placenta, or intestine. So sometimes the normal pattern is the liver alkaline phosphatase isoenzyme is the highest. But sometimes in patients, if we feel that we want to know the origin of alkaline phosphatase, it could be from bone as well, and we do these isoenzymes. So in this patient, bone alkaline phosphatase was raised. And why? Because PTH uses alkaline phosphatase PTH, elevated PTH uses alkaline phosphatase to go to the bone, resorb calcium, and maintain the calcium level. So in this patient, this alkaline phosphatase was not high because of probably excess alcohol, but it was high because of the bone component coming from high PTH. And then carbohydrate deficient, the transferrin is a test that we do at Homerton for patients when there is a suspicion of excess alcohol intake. And in this patient, there was no evidence of excess alcohol intake in last 14 days. Because a patient who has a history of excess alcohol intake in past, there is always a suspicion, is the patient underestimating his intake himself? Or it's always, we worry that if this patient is given a gastric bypass surgery where alcohol will be absorbed more quickly and this patient can be at risk. So this was required. And so this patient had elevated bone ALP enzyme in presence of low vitamin D and high PTH. This ruled out fatty liver due to excess alcohol. So this was reassuring. Again, normal CDT, reassuring. High triglyceride levels that we see, and which was prompting towards excess alcohol, because when a patient has got excess alcohol intake, their triglyceride metabolism is impaired and it is high. But so it was like, the MDT is trying to figure out, is it excess alcohol? Is this a safe patient for surgery? But when we queried when the detailed history was taken, this patient had problems with the statin. So the statin is the drug for atorvastatin, rosuvastatin are the drugs for hyperlipidemia. And if a patient is not regularly taking, their triglyceride or LDL cholesterol levels will be high. Now, this patient had a low vitamin D. We know patients with vitamin D deficiency are statin intolerant. So this patient was not taking his statins because of muscle aches and pains, which were because of secondary hyperparathyroidism and vitamin D deficiency. And again, very high triglyceride levels can also pose a risk of acute pancreatitis. So the first thing that should be done in such a patient is treat vitamin D deficiency. And this patient was treated with 300,000 IU of intramuscular injection, which improved statin intolerance. So gradually over next 4 to 6 weeks, patients could start taking atorvastatin and still was having aches and pains. So it was replaced by rosuvastatin, which is a more water-soluble statin with less side effects patient could tolerate. So the triglycerides started coming down, LDL cholesterol started coming down, and the patient was able to exercise more because his vitamin D deficiency was corrected. This patient could institute more lifestyle and dietary modifications with the help of the AHT team and resolving most of the complications. So with this workup, when the triglyceride levels, vitamin D, and other things were managed, and the risk of acute pancreatitis was also reduced, this patient was referred back to the MDT for consideration of bariatric surgery. So just to summarize, positive clinical outcomes post-bariatric surgeries govern increased referral rate for surgeries, allowing more patients to get the much needed surgery. I always maintain these surgeries are life-saving, life-altering. Somebody who has accumulated weight over 30 years can get rid of this weight, plus the metabolic benefits and resolving of diabetes in less than 1 year immediately. So these are life-saving, life-altering surgeries. More and more patients should get it, but with more vigilance and pre-operative optimization prior to going for surgery. And a cohesive MDT team with as many different specialties as possible, even including pharmacists in the panel if possible, in addition to all the members that I have said here, is mandatory. And I see more and more disciplines coming because these surgeries are increasing. And a robustly optimized patient preoperatively is directly proportional to best clinical outcomes. And seeking help from your chemical pathology teams and pharmacists regarding interpretation of multiple deranged biochemical blood test result profiles or drug effects respectively is required, because sometimes I feel that as a AHP team, you are asked to interpret a lot of things which are not in your remit. And again, NHS, I can talk for NHS in the UK, we do not have that much resources, especially after the pandemic. And to add to the insult, we are so short of tubes at the moment that we have to really ration the tests we are doing, which were freely available probably 1 year back. So taking advice from your duty biochemist, chemical pathologist, and on-call pharmacist is something that can help you do your job better in terms of patient benefit, for MDT benefit, and overall performance. These are the guidelines which I had the privilege to co-author with Mary, the lead on this area. And like I said, this is life-saving for clinicians, and a simpler version for patients will be, again, a gift to mankind, I can say. My acknowledgements, Mr. Sanjay Agrawal, my bariatric MDT colleagues, all of them operational, clinical, admin, and beyond. My colleague consultant chemical pathologist, Dr. Jeffrey Barron, and lab manager, because without them, I will not be able to do any of these tests, which I do. And last but not the least, before that, my IT specialist who helped me with this presentation, but most importantly, the patients who have allowed me to look after them and be part of their journey. They shared their stories, and with the help of my entire team, because nobody can do one thing alone, with the help of all these people and who I have not mentioned here, and Venkatesh and Danish. Thank you so much.
Thank you very much, Manisha, for such a brilliant talk, as always. Very interesting case studies. So we've got a couple of questions, one from the delegates. What is your view on preoperative liquid diet management for liver size reduction?
I think my colleague dietitians are best placed to say about this, but as far as I know, that it works for our patients, because some patients who come to me after their pre-op diet, they do very well even in terms of the biochemical markers. Sorry, am I audible?
Yes, ma'am, you are audible.
Yes, you are audible.
Okay. Yeah, so the liquid diet, some of these patients who follow our dietitian's instructions, because they have a detailed leaflet for different modalities of treatment. When I see them in my clinic, I usually see more post-operative patients, but any complex pre-operative patients, if I've seen they have marked reduction in their triglyceride level, their gamma GT, their liver transaminases, and I can see their fatty liver is reducing even on the evidence part of biochemistry. So it works beautifully.
Thanks, Manisha. The next question is from Mary. Given that many areas cannot request MMA, how can we convince GPs to treat low levels of B12 as they are still within normal limits? Very interesting question.
See, I think you will be able to find studies where they say that serum B12 is not a good marker. We have a long data of 9 to 10 years, which I need to really work on it, because there has been no time to publish, but I need to work on this and work with Mary and other colleagues. We need to publish this data where we have enough data to show that patients more than 500 are still, so if the range is 200 to 1000, patients more than 500 are safer, because we have seen on all these patients that they have a normal holotranscobalamin and a normal MMA. But patients of 450, which might seem completely normal with the reference range of B12, can have severe deficiency with very low holotranscobalamin and a high MMA. So what we do, because again, in Homerton also, we have now limited capacity because it's an essential service lab now in partnership with a bigger hospital, Barts Health. So we have even cut down on MMA. So we have to live with that. And the strategy that I have applied with our team is that anything less than 500 should be treated. Luckily, we are in a position where we can convince our GPs better, but hopefully with some time, we will be able to come out with a publication where you can quote this, that this is specifically for bariatric patients.
Thank you very much, Manisha. So I think that concludes our session. I have to say there have been a number of questions that have remained unanswered for this session. So what I would suggest is that these questions can be directed towards the speakers perhaps during the refreshment breaks. And the lounges are available for the delegates to communicate and to interact with the speakers if they feel that their questions have not been answered. Thank you.
Thank you very much, Sarah. Thank you, everyone.